The average guy who joins our TRT program will almost double their income in 18 to 24 months. That's a pretty fair statistic that I tell people.
What?
Yeah, guys.
Holy cow. People that come in and get on TRT with you are doubling their income in 18 to 24 months.
It's not me. You know what I mean? That's just what happens when someone is an effective motor.
What's up, guys? I'm here to tell you this episode is brought to you by Crowd Health. Crowd Health is a new, fast-growing, tech-enabled, well-capitalized, community-powered alternative to traditional health insurance. Founded by Andy Schoonover, a proven founder and entrepreneur with a successful track record, including a $100 million plus exit. By the way, Andy's been on this podcast in the past. Crowd Health uses the power of crowdfunding, member ratings, unlimited choice, and huge cash pay discounts to provide a simple, considerably less expensive solution to managing your medical bills. Crowd Health gives you full agency and sticks with you no matter where you move or what jobs you take on. You've heard of Big Pharma, but you may not know Big Insurance is actually the man behind the curtain. With 12 of the last 15 heads of the FDA taking jobs in Big Pharma and 64% of its funding coming from private industry, don't hold your breath waiting for the government to save the day. It's safe to say our system's broken. It's time to take your well-being into your own hands, and Crowd Health helps you do just that. You'll pay into your individual account monthly, and if you ever want to leave, you'll simply pay a $250 closing fee, and they will return the entire balance in your account to you because it's your account. Because it's crowdfunded, we all have a vested interest in each other's health. They even cover up to $300 a year in routine wellness visits. So far, for every $100 members have paid into their accounts, an average of only $30 has been paid out. So you can expect to see your money grow in your account over time. Take that, Big Insurance. Join today by visiting joincrowdhealth.com and using the promo code KLP to pay only $99 a month for the first 3 months. That's joincrowdhealth.com, promo code KLP. Joincrowdhealth.com. Get you some. Hello, Doc.
Hello.
Welcome to the podcast. All right, in a second, I want you to share who you are, what you do, and how you got into it. But first, I had my first experience with electrolymphatic therapy today. Do you know much about that?
There are several types of lymphatic therapy. I don't know that I'm familiar with the electrolymphatic
Okay, this was
therapy.
with Soma Wellness on the east side of Nashville. And about a month ago, 5 weeks ago maybe, I was pretty sure I had Hodgkin's disease. As it turns out, I don't think I do. But I scheduled a blood draw. I changed my diet, and the diet just cleared it all up. But this was on my radar, they have this. It's an hour session. You kind of lay on a bed, and it's like this these wands where they roll. It's like an electrified roller, like a light roller that they were rolling all over. I thought it was just going to be in my neck, but then they wound up rolling all over the body, really. Mm-hmm. And, dude, it zen me out like crazy. I felt like I had a massage after that 1 hour ELT session. Felt like I had a massage. And this afternoon, or tonight, rather, I was in the sauna. And, it felt like I had come out of a float tank. It was really fascinating. So I just wanted to, clear out my lymph nodes. That was a new experience today, which was fun. But yeah, let's jump right into.
Well, have you noticed anything else since you did the therapy? Did you notice any change in your urine? Did you notice any change in your sweat when you were doing your sauna? Like the smell or anything about it?
No, I did taste metal in my mouth a little bit.
Interesting.
Which someone had mentioned you may, if there's enough of things in your lymph nodes that it's clearing out.
Right.
So during the 1 hour process, I did have the taste of metal a little bit, and then on the drive home, I tasted it again a little bit in my mouth. Urine looked regular. Nothing noticeable there. I just was drinking a lot of water this afternoon. I try to drink a lot of water anyway, but I drink a lot of water. But yeah, it was really strange. I was in the sauna and I didn't notice anything in terms of like the ability to stay in longer or anything like that. But I like to go sauna and then the ice tank and then back in the sauna. And when I went back in the sauna, I had turned it off. And so I was just riding it from like 175, the temperature down. And, I was like about as calm and still as the closest thing that I've ever experienced was a float tank.
Yeah.
I just didn't expect it to like zen me out like that.
Right. Give you that calming feeling.
Yeah. But it made my leg a little bit sore. I give myself a shot in my leg, which we might get into TRT and HRT later.
Sure.
But I use TRT right now. And so every 4 days I'm giving myself a shot in my thigh. And, it made the shot site in my leg sore.
Yeah.
It's never happened before. But it felt good. I wasn't expecting it to feel like a massage. I was expecting it to feel like something almost uncomfortable and just to work on my neck, but it was full body. Apparently I had, the roller stops rolling if it like experiences build up in proteins in your lymph nodes. Mm-hmm. And apparently I had build up in my neck, under my pectoral muscles and up my side, but the rest was pretty clear.
Interesting.
Yeah. All right, let's just jump right in. You want to share with everyone listening who you are and what you do and how you got here?
Yeah. So my name is Dr. Lee Howard. I'm board certified as a surgeon, general surgery, and still maintain my board certification. And I stopped operating about almost 5 years ago now. And that was a culmination of a lot of years of investment in my time and energy and learning a new skill set as a doctor. And in 2010, I graduated residency, a long, grueling process, right? And after coming out of that, I realized that there was a lot of changes that had taken place in my body, both a part of age, right? And part of it was the stress and sort of the situational changes. So at first, in 2010, I thought, okay, I didn't really go to things like hormones at that point. I thought my diet needed to be my first sort of real change I made. So anyway, starting with myself in about that 2010, 2011 time, I started to really focus more on health prevention instead of being that reactionary surgeon that only is kind of taking care of people when it's acutely a problem. And I incorporated those principles throughout my patient care days as a general surgeon, and I saw a lot of good results with that. And so I knew, and as I aged, I learned more about my own health, the approaches that I took, the tools that I used. I expanded my knowledge and expanded my skill set. And so as I aged and continued to do new therapies like TRT, for example, and even refining my diet further, so my point is I started to really think about, like, this is going to be an evolution for me, and that means it's an evolution for everybody else, right? And so instead of contributing to a system that I no longer felt was actually helping anybody or moving the needle in the right way, I wanted to create a place, a location, a set of minds, a set of services, a set of people who were dedicated to the opposite of what healthcare was doing and what I had been trained to do. And instead providing invest in your health now, not your sickness later. Mm-hmm. And we wanted to use therapies that were going to be anti-aging, that were going to be inflammatory reducing, and allow us to live optimal lives. So one of the concepts we talk to our clients about is targeted maximal longevity. It's there are several variations of this that other doctors have come up with, but essentially it's what I think most people want, which is functional longevity. We want to live as long as we can, to as great of a capacity as we can, with as much impact as we can. Mm-hmm. And so as my healthcare journey sort of started, I started to add services and do things that led me down the path that I was going. And I knew if I wanted that, there was a lot of other people that did too. Mm-hmm. And so, that's what we've done. We built Compass, and we're in our 5th year now. And Compass is, I think probably the most comprehensive regenerative facility in Nashville for sure.
Oh, really?
Yeah. We're well versed in peptides, with our stem cell and regenerative medicine applications. We offer a full range of regenerative orthopedics. from the performance side, using ozone and our customized IV therapy really is a winning combination for everybody. So, I mean, I think we put together a great suite of services that most people can find value in.
Mm-hmm. Well, I found you through a guy at my gym, and he was getting, maybe still is, getting NAD treatments with you. And he was talking about it, and based on what he was saying, he was speaking very highly of your practice. He also mentioned it was where he found, was it any chance you sell quercetin?
Of course.
Okay. Oh yeah. I think he was saying that's where he found quercetin in the middle of the pandemic, and his wife had actually found your practice somehow, and then knew what he was looking for, and sent the link to him. And so it sounded interesting. So I looked up your practice, and my goodness, you're into like all the good stuff.
Yeah.
I was super stoked about tonight, man. I was so stoked because like I think I might have said this in a text, but I legitimately feel like a kid in a candy store. Like the stuff you're into is really, really fascinating.
Yeah, it's a great thing to be part of.
Yeah.
Because it's a much different outcome, right, than what I was trained to do for so long. And in that system, you don't get to pay a lot of attention to what the client's goals are. That's not really a meaningful part of the conversation. But now my interactions are much more geared towards helping my clients achieve the outcome that they desire, right? Helping them, because not everybody wants to push that hard. There's different people who are not going to cold plunge, right? Like you and I will go to the sauna and cold plunge, and we're okay with that discomfort. There's just some people who aren't going to do that. So we meet them where they are, right? But yeah, with the way that I see these regenerative therapies going and stuff, we definitely have an opportunity, if you are open-minded to trying these therapies, to not allow yourself to get old and to experience what so many people think are just the commonalities of aging. It's the commonalities if you do common things, right? That outcome is likely to happen to you. Do what everybody else does, and you're likely to experience what everybody else does. And we know that we can offer an alternative to that, And the pandemic opened up a lot of doors for us because we were early adopters on the hydroxychloroquine train.
Okay.
And we started doing that probably April, May, maybe something like that.
Of 20?
Yes, right.
No way.
Yes, 2 months into the pandemic or something like that, we were selling. Well, I mean, I think it's important to share this story with people, right? So people ask me like, well, why did you know? Because just a couple months later, we were doing ivermectin, right? So I think one thing that I have found and sort of a litmus test, if you will, or a measuring stick that I use is that, and a lot of people forget this. Everybody wants to know, well, how much of a likelihood does this therapy have in helping me? Not a lot of people ask the opposite of that, which is how likely is this therapy to harm me? Mm-hmm. And oftentimes regulators make a decision based off of the first one, not on the second one. And so good options are taken off the table, not because they're still good. They just may not be as good as another therapy, but they still have very low risk of harm. Mm-hmm. And so for me, when you look at something like hydroxychloroquine or ivermectin, there's a huge amount of potential, but there's basically zero risk to taking that medicine, right? If we were to walk into Brazil, and I'm sort of using that loosely as a catchphrase, but the point is that if we walked into most third world countries in the world, specifically if we were going on some kind of Amazon rainforest expedition, they're not going to ask you to take hydroxychloroquine and ivermectin. They're going to make you, because in 48 hours, they're not bringing your malaria-infected ass out of there, for a 7-hour trek down the river that they just did the day before. So that's the ideal prophylaxis. And in fact, what sort of led to this was, as an epidemiologist, and I'm not, but I'm just a guy who looks at the data said, why are we not seeing outbreaks of coronavirus in the equatorial belt around the world? So you start to ask questions like, okay, is it behaviors that they're doing? Is it something that they eat? What is it they take? Because it's important to know where the outbreaks are. It's also important to know where their outbreaks aren't, because there's a similar characteristic there too, right? So we knew that there was a high likelihood that ivermectin and hydroxychloroquine were playing a role in this. And so then there was a study that came out very early, I think it was probably in like August or September, from Argentina, which had basically sent two groups of nurses into the hospital, one prophylaxed with ivermectin, one not. The contraction rate I don't want to quote the study exactly because I don't remember the numbers, but basically like 0 out of the ones that were prophylaxed with ivermectin got coronavirus, whereas like 70% of the other ones didn't. But the numbers were pretty clear, right? And so I also had the opportunity in med school to study under a guy named Caleb McPherson. And McPherson was a parasitologist from South Africa, and he had been involved in the original studies on ivermectin and treating river blindness in Africa. And so what I learned about treating that disease was that you treat it with very high doses of ivermectin, typically for years. So when you saw the potential that with 2 doses of 12 milligrams that we could basically cure COVID, and you know that people were taking 60 milligrams a day for 5 years, right? Then you start to do the math and you look at that and you're like, well, if those high doses that have been used for, the last 40 years or 50 years haven't really had any major impacts in terms of side effects or lethality, then 12 milligrams certainly is not going to have a high risk, right? So to me, it felt like there was a very small amount of risk there.
Did you have trouble with your supply with ivermectin and
So in Tennessee, the state
how do you say it again?
Hydroxychloroquine.
Hydroxychloroquine.
Yeah. I mean, so I guess the answer to your question is yes, we did. We did have to source it. We in Tennessee, we have some laws favor physicians who are able to kind of have an office pharmacy, and so if you are so inclined as a physician in Tennessee, you can dispense medications to your patients. And so what we were able to do was we were able to source from a pharmaceutical supplier the ivermectin, and then just like if you were going to a pharmacy, we were able to dispense. So what we did was we started an online platform where people who were looking for COVID treatment, we found out basically that people fall into 3 categories. They're either looking for acute treatment, prophylaxis, or recovery, right? Of course.
And explain prophylaxis.
Taking ivermectin or hydroxychloroquine in order to keep from getting sick, right? And so what we did was we would send people to our website. They would get qualified by answering a few questions. What are you looking for? And then we had a way to help each of those 3 categories. And so that, when you mentioned the quercetin, like we really became a one-stop shop for everything that people could need for COVID. So I had aspirin, where every male got aspirin, vitamin D, quercetin, zinc, selenium, budesonide for pneumonia, inhaled other antibiotics, IV antibiotics that we were doing. And then we were treating people, naturopathically too. We were doing high-dose vitamin C therapy. We were doing even stem cells and exosomes for people who wanted to go that route. So we had a pretty wide variety of ways that we were treating people with COVID. And then now that's continued into long COVID. I mean, it was September of 20 when we first started seeing long COVID symptoms. And we've seen it all. We've seen, the brain fog, the hormone disruptions. I've seen lower extremity paralysis. And I mean, I've seen some really devastating things come out of that.
Lower extremity paralysis from COVID?
It's a Guillain-Barré type syndrome, right? Where someone gets sick after that episode, and their neurological system starts to kind of be affected by that. And I believe it's probably more of an autoimmune thing, right? Meaning that the virus triggered some sort of immune reaction that's now calling like a polyneuropathy almost.
Sure. So there was no point in there where you were not able to have a supply of ivermectin or hydroxychloroquine. You were able to offer it that entire time.
Correct.
Okay. But not everyone was, correct?
Yes, that's my understanding.
Some states or some... Wasn't the federal government trying to limit ivermectin?
Yeah, I think it was more at the state level. I think it was more at the state level. I think because what happened was that doctors were trying to send prescriptions in and pharmacists were rejecting it. So was that a directive from on high? Possibly. But
for ivermectin?
Correct. Yeah.
Why were the pharmacies rejecting a prescription from a legitimate doctor?
It's not FDA approved, right? It wasn't an FDA approved indication for that drug. Neither was hydroxychloroquine. Hydroxychloroquine is used primarily to treat rheumatoid arthritis, and as an anti-malarial prophylaxis drug, right? A malarial prophylaxis agent. So I think it was probably more at this. Now I don't know where the directive came from, obviously, but I think the stoppage point came at the transition from a prescription to it getting filled to a patient. Right?
Okay, and was the FDA working on approving ivermectin as a treatment for COVID?
That was not going to happen. That was not within the plan, in my opinion, right? And I say this having now, of course, the only difference between conspiracy theory and the truth is about 6 months or so now, right? But
that's exactly right.
Back then, it seemed to me that the reason why ivermectin was not recommended was because it wouldn't allow the natural pathway for something like a vaccine to get fast-tracked, right? And so this EUA, this Emergency Use Authorization Act, and I don't pretend to be an expert in that, but my understanding is that if there is a drug that can treat the said disease, then that EUA can no longer be enacted or legitimately enacted. And therefore, because you don't get to then fast track certain therapies, you don't get to go through certain exemptions without that thing being in place. And so that basically, at that point, once you bring that in and your goal is to get a vaccine, then you almost by default, whether you are in possession of said knowledge or not, you have to deny everything else. Because otherwise you have no reason to push this EUA philosophy and then fast track this vaccine and continue to keep people in their homes and, do all the sort of societal mistakes that we've seen made.
Did you have any of your patients have an adverse reaction to ivermectin or hydroxychloroquine?
People say they get bellyache or something. How much of that is
on 12 milligrams?
Well, I mean, that my point is that you're also taking other supplements at the same time.
Okay.
Most people are not just taking it in a vacuum. And then you also have a severe viral illness going throughout your body that in a certain percentage of people causes GI upset. So what percentage of those people had belly pain, abdominal pain, quote unquote, because of the ivermectin? I'm not real sure. I honestly don't think it's high at all. Worldwide studies show that ivermectin is basically as safe as aspirin, when it comes down to it. So maybe even safer. But the point is that I did not see anything that I felt to be concerning or what I would consider to be adverse.
So you had, during the entire pandemic, I could have came to you when I got COVID in August of 2021, and you could have prescribed me ivermectin.
We would not have written a prescription. We would have dispensed it through our office pharmacy. But I would not have. But you see, the benefit of that is that I don't have to now open myself up to the scrutiny. See what I mean? Because this is what would happen. A doctor in Kentucky would write a prescription for ivermectin, and the pharmacist is going to call the state board and say, okay, Dr. Smith just sent a prescription in, and that doctor's going to get a phone call from the state board. That was happening here in Tennessee, by the way. A lot of people don't know that. But
from the Tennessee state boards?
Now, they're sneaky. They're not stupid, I don't know if you guys know who the Tennessee Commissioner of Health, her name is Lisa Piercy. She's a very pro-vaccine pediatrician that used to run some hospitals for West Tennessee Health. But Lisa Piercy was very much into the COVID narrative. And, nobody wants to be it's not going to be the Tennessee Department of Health that's going to go out and sort of get after doctors, because that would be a very easy way to trace back, and they would be kind of the first culprit, sort of identified.
The Tennessee Department of Health would be?
Correct. Yeah. I mean, if a doctor gets a phone call and is, asked to, either clarify what they did or to do something, it's going to be by the Department of Health. But what happens if, say, the Tennessee Department of Youth Services call? And they say, we got news from a mother that you are spreading COVID misinformation out of your clinic. So now that's not as easily traced back to any specific person, right? And this was all swept under the rug. There was actually a meeting. There was some pro-choice, if people, what I mean by sort of pro-choice, like you should be able to get vaccinated if you want to or not. And these people were lobbying with our state legislature. And they actually asked doctors to come up and say, tell us what you were told. Tell us about the phone calls that you got. And doctors wouldn't come forward. And we knew they were out there. I got contacted by at least one person who that happened to. And it was all under the guise of a child protective type services or child welfare call kind of thing. So that it couldn't be traced back to the Department of Health. And I do not under any circumstance believe that was accidental.
Okay. Yeah.
That's just a pathway so that you don't get caught with your hands in a cookie jar.
Yes. Well, that's kind of interesting because some of the same stuff is happening in Canada with the transgender things. Like if you're 13, my understanding is if your 13, 14-year-old kid believes they were born with the wrong gender, then the parents can't give them counsel that's adverse to that at all, and the kid can do whatever they want. And it's almost like there's another example of the state having an agenda and then going through the kids to accomplish that agenda. Like if these doctors are getting called by who was it that's over the kids? You say
Child
protective services.
Child protective services. Yeah.
Instead of the Department of Health, that's clearly like they're using that as a cover.
Mm-hmm.
So you were able to provide ivermectin the entire time.
Correct.
But how is it that you just have like your own? How can you sell out of your own pharmacy and you don't have to write a prescription? Or does every doctor have that?
Well,
or
we still see
are you
patients,
a pharmacist
right?
also?
We still see patients, right? So in other words, I would see you and make a recommendation, just like we had to have a logical progression of where that went. Now in Tennessee since last year, you can buy ivermectin without a prescription in Tennessee, right? So now you can come in off the street and buy it, just like you can get Advil off the shelf at Walgreens. And no, I mean it was a transfer of, we see Kent, we have a positive COVID test, and based off of these risk factors, we recommend this dosing schedule, and that was put into your medical record, and then that was then transferred over to our pharmacy log, where we then took record of the drugs that were dispensed to you with lot numbers and the quantity and what the expiration date was, and put it in bottles with labels on it, just like you would get at a pharmacy, and you were out the door.
Did you notice ivermectin and hydroxychloroquine being helpful for your patients that had COVID?
Absolutely, beyond a shadow of a doubt.
Oh. Wow. Okay, so how can something like this happen, and the powers that be try to limit people from getting ivermectin and hydroxychloroquine when it's clearly helpful? How is that not criminal?
Well, I wish I had the answer to that question as to why this is not, why there's been no real push to sort of hold people accountable for their actions. Because, if you, in my opinion, as a free-thinking individual, if you look back over the last few years, you look at sort of where we started in March of 2020 with the narrative, with the actions, and then just follow that to where the trail has naturally led us to now, like, okay, we recently had a Pfizer CEO admit that they're doing gain-of-function research, through an uncover interview with Project Veritas. And so, if you can't look at the data now and go back 3 years ago and say this was sinister, that this was really, it smells really freaking bad, and I think that if you can't look back and say, at least be more skeptical, if not be completely convinced that this was an sort of an orchestrated effort to do certain things, to make big pharma more money, to increase control over the population by the government. We can talk about a lot of aspects to that, but at the end of the day, it was a success in their book, right? Because they got a lot of people vaccinated, quote unquote, and they were able to see how far they could push people. And anyway, I just think back now that it did happen, and I think a lot of times, and I know this is probably not going to set well with a lot of people, but it's because, number one, the people in charge are used to acting on their feelings and not data. And they were put in a place, so I don't know if you guys know this old sort of wives' tale about a thing called a post-turtle. Have you ever heard of this? Post-turtle?
No, I haven't. Post-turtle?
Yeah, post-turtle.
No.
I don't know if we have the opportunity to look it up so we can get an accurate definition.
Yeah,
but the point is that basically, if you were walking down a country road and you saw a turtle sitting up on a fence post, you would know there's several things. First of all, the turtle doesn't know what in the hell to do when he's up there. Okay. The second thing is that whoever the jackass was that put him there had no idea what he was going to do when he got there. Right. My point is that
you're okay. So you're saying there's no way a turtle can put himself on a fence post.
That's right. And some idiot had to put him there because a turtle on a fence post has no real is not helpful to anybody, right? It can't move. It can't do anything. So basically, See right there where it says, that.
Yeah,
Go to
click on that.
top
A
one,
post
yeah.
turtle that
You're driving
H.com.
down a country road, right? You see that? So there you go.
Candidate's a post turtle. When you come across a fence post with a turtle balanced on top, that's a post turtle. Scroll down a little bit, Kobe. Let's see what else it says. Yeah,
there it is.
you know they didn't get up there by themselves. They don't belong up there. They don't know what to do while they're up there. And you just wonder what kind of dummy put them up there to begin with.
There you go. Okay, so people
I've never
we
heard
had
that
in
term
charge
before.
was post turtles. Well, that's what we had. You got Becerra up there. You watch Rand Paul grill him. He's like, what healthcare experience do you have? None. You listen to people who.
I see where you're going with this.
This is what's his name? Jim Cramer. Jim Cramer has a huge following in the stock market. Huge following. And this numbnut is going out there telling everybody, you should get vaccinated. You're a criminal if you don't get vaccinated. General Petraeus goes in front of Congress and demands that we do not drop the vaccine mandate for soldiers. Well, I just want to ask each of those people, what data do you have? What set of numbers are you in possession of? What experience have you had that allows you to make that call? Because the rest of us don't have it. And, when this all happened, I remember we were on spring break with my family. My wife's a pediatric and neonatal ICU nurse. And we had been, she had lived in New York City and had lived outside of New York City and New Jersey. And that's where she and I met. And we were training in that area. And then I was training over at Lehigh Valley Hospital in Pennsylvania, big 1,000-bed hospital, about an hour outside of Philly. And my point is that we had trained in these bigger and closer to inner city hospitals for a portion of our career. And throughout that time, we had seen other pandemics come through, H1N1, swine flu, all these other things. And so we knew that young people had died from that too, right? This was not something new. A respiratory virus that can kill young people is not something that is just invented last week. But suddenly these post turtles are there, and instead of having some background knowledge, some background in what they were actually making decisions on, they were just allowed to express their feelings, and everybody just sort of on Twitter just sort of rolled over and said, okay, I guess this is what we're going to do. Mm-hmm. And, I tell this story too. I had a roommate in med school who was a New York City born guy and really didn't have any knowledge of firearms. And so here I am in my second semester of med school. We start rooming together, and I'm a big proponent of the Second Amendment and firearms training. And, this guy starts to tell me that he thinks that all firearms should be outlawed. And so my first question was, well, do you know what the difference between an automatic and a semi-automatic weapon are? Could you know how to operate it? Answer was no. So I'm like, so wait a minute. You think that you're willing to make a decision on something that you basically have no idea what the actual substance is. Right? You don't even have a background knowledge of what you've already made your mind up on this. And that was my first real exposure to people who were so close-minded to thinking.
Yeah. Lex, did you ever hear Lex Friedman?
Yes.
His podcast. Yeah. I love his stuff too. And he was in Ukraine last year, and I believe he's from Russia, but he has a lot of family or some family in Ukraine also. He said when the war started, Ukraine gave everyone guns. Everyone was given guns, and crimes dropped off, totally dropped off. Now, it could also be because people are more busy
fighting for their country and stuff.
Fighting for the country. But also, that doesn't entirely explain all of it, because usually when the chips are down, there's people taking advantage
of other people, right? The weaker
ones,
that's right, yeah.
Storefronts and such, but everyone had a gun and there was no crime.
Yeah.
So I don't know if that translates, into peacetime or not. But do you think the whole COVID thing, what I saw in COVID, I'm glad that I am the age that I am when that happened, because if this would have happened when I was 20 years old, it would not have seemed, I don't think, to me, I don't know if I could have seen it exactly for what it was. But being almost 40, you've been around, you have some experience. What happened in COVID is terrifying to me. It's scary. Because it did seem like there was a very particular narrative that was at a lot of people's expense. And there was no movement around that narrative. There was no gray edge around that narrative whatsoever. And it was like there was a very clear objective that everyone was on board with, and including the news outlets. Mm-hmm. And you could hear it by the way they talk about it, the way they try to cast doubt and fear, and that's really scary to me. And so where did that narrative come from? Do you think it came from Big Pharma that infiltrated the government? Do you think it came from the government and then Big Pharma got on board with it? Or at this point, is it so convoluted you can't really separate Big Pharma and government, and it would be impossible to decipher where this came from? This narrative that these things don't help. Ivermectin is dangerous. Hydroxychloroquine is dangerous. They start limiting the supply. Doctors don't get to fill prescriptions. No one's talking about vitamin D. It's all, stay indoors, which is interesting. Stay indoors, mask up.
Close down your gym.
Close down your gym. Close down your businesses. I mean, when they wrote the Bill of Rights, they had pandemics back then. This is not a new thing. There's no exception in there for pandemics, is my understanding. I mean, correct me if I'm wrong. I'm not that smart.
I'm not. Yeah, I'm with you though.
I don't think there are exceptions for pandemics in there, and they're not a new thing.
Yeah.
I mean, a lot of people thought COVID was going to be a lot worse than it was, and thank God it wasn't. And look, a lot of people died from COVID, but it wasn't the worst one by any stretch, right? I mean,
that's right. That's right.
Way worse. I mean,
absolutely.
In terms of
by their own measurements, NIH, CDC, whatever. I mean, it was even less than what they would consider to be a moderate flu season, right?
Exactly.
So at worst, this was a mild flu.
Exactly. And then you have Fauci, who's sort of the spearhead of this whole thing. Whatever he says goes. And at some point, it didn't take this long in the pandemic for a whole segment of people to just wholesale get on board with Fauci, like all in, gung ho, no questions asked, whatever he says goes. And so here you have this figurehead who's blatantly lying. And, well, first changing his mind on a few things, but blatantly lying. And so I'm just wondering, where does this come from? Is it Big Pharma that's behind it and getting the government on board, or is it government and then Big Pharma sees an opportunity and they get on board with it? How do you think about that?
A long time ago, when I was a kid growing up in the country around here, it was, somebody always said, if you want to know who's kind of where the sinister people are, follow the money. And so if you look at the three groups that stand to benefit the most, it would be large hospital corporations, one of the largest or the largest of which is anchored here in Nashville, right? Ascension, largest not-for-profit healthcare center anywhere in the world. And HCA, arguably number two probably, right? So it is said that 85% of all healthcare decisions, quote unquote, and when I say that, what I mean is more like policy type stuff, reimbursement, originate in Nashville because of I know that's kind of startling.
Say that again.
Now, I may have this statistic off, but I was told this years ago. 85% of all healthcare policy decisions originate out of Nashville, because you have Ascension, which controls so much of the market, and HCA, which controls so much of the market, right? So they together wield a very big stick, right? And so that's huge stakeholder. The next stakeholder is your insurance companies, right? So they are an insurance company. And what a lot of people also forget is that Medicare basically covers about 51+% of the population. So by default, they are the country's largest insurer, which is the federal government. So the federal government now becomes the second leg of that stool. And so insurance companies, hospital corporations, and then, there's the third, which is pharma, right? So to me, in my opinion, and looking with the help of a retrospectoscope at this, it seemed that there are the people who were looking at China saying, okay, we see what's happening. We know that this is likely to spread, and we need to position ourselves to financially make the most money off of this that we can. Now, whether or not that was conceived in some back room somewhere a couple years ago and it was really planned out more than that, I don't know. But I do know that at that point, there were steps taken, as you said, to get everybody on board, right, from the top down. We're talking about FBI censoring things, right? We know all this stuff with Twitter files and all this stuff that's been coming out. We know it was censored. We know it was guided. We know that it was strategic. And so to me, it was a correlation between that three-legged stool: pharma, big insurance, and hospital corporations.
And in the most generous assessment, they saw what was happening early because this is their job, and they saw an opportunity to push a vaccine.
Well, I think even more than that, right? There was the end point was to get a vaccine, but there were several steps that had to get there. Emergency use authorization was one. Mm-hmm. There had to be a certain amount of fear and a certain number of deaths that are going to make people adapt to vaccine, right? Because if it's only like, old fat people that are dying, then other people are going to look at that and say, well, I'm not really taking that jab, Right. But if you can make young people die of this, then their young friends are going to take the jab too, right? So you can see where things like not withholding therapy, or when I say not treating people or withholding therapy, not allowing their families around to help them make decisions. There were just certain behaviors that you look back at this and you say, man, that it just smells too bad. Mm-hmm. I mean, if as a doctor I did some of the stupid things and said some of the stupid things that these people did, I would be kicked off the medical staff of a hospital, right? Like, I mean, they're just grossly incompetent, most of these people. And I think the sad part is, Kent, this is what really bothers me, because so many people I see coming in my office have just accepted mediocrity as the sort of best that they're going to get. And I just think that is so sad. And so right now we've kind of set this test, or set this metric, if you will, this litmus test of mediocrity is okay, mm-hmm. right? That it's okay to be overweight. It's okay to be scared and be paralyzed into no decision. And I just don't think that's the standard we need to set, right? I don't set that with my kids. And I don't think that we need to do that in society as well. And unfortunately, this post-hurdle analogy, I'll give you another sort of perspective on that. We're driving down the road. I got my daughters in the car with me. It's like 27 degrees. This was last fall, and this is fall of 21, or wintertime. There's a lady walking down the street who has a mask on and a coat on, and it's 27 degrees outside, 7:15 in the morning. There's no one around her on the sidewalk, right? So I tell my daughters, I'm like, look, that is a person who is allowed to have a voice. That is a person who is allowed to speak up, and some people are going to take that opinion seriously. But you can look at that situation, you can look at that person and say they probably don't have a clear understanding of what their risk is. They're probably paralyzed into fear, and the reason they made their decision to wear that mask on the sidewalk with no one else around them. And so should those people then be allowed to actually influence policy? It's okay that you have your feelings. It's okay that you express your opinion, but it shouldn't fall into the realm of public policy. Mm-hmm. And I think that we've kind of gone too far with that. Mm-hmm. We've allowed feelings and sort of some of those, the American College of Surgeons has not come out and spoke out against transgender surgeries, not that I'm aware of anyway. And I do get the American College of Surgeons bulletin regularly. And, in the past, the American College of Surgeons would have only supported surgical intervention for things that clearly had indications for it, mm-hmm. right? Where we had data that showed outcomes that were desirable. We don't have that. Mm-hmm. And yet we haven't spoke out against it, right? Yeah. So what point have you compromised your moral fabric to the degree that you are now stooping to this low?
Mm-hmm. I heard Jordan Peterson say recently, I think it was on Joe Rogan's podcast, the last time he was on, just last week it came out, that 90% of all transgender surgeries, when they're like 12, 13, 14, 90% of the time that clears itself up by the time they get to 18 or 19 years of age.
Yeah.
And 80% of them are gay. So like we're not protecting minority interests here, because the last time I checked, being gay is still less common than heterosexual. So you could look at that as a minority. Here's a minority group of people they're not being protected. Mm-hmm. And he also said, I believe, that 1 in 3,000 kids would actually qualify for like a legitimate transition, but not the it's become a what did he call it? A psychological epidemic. It's like spreading.
It is.
And I hadn't heard this before, but this is not a new thing. Like cutting was a psychological epidemic, anorexia, bulimia, and he listed 2 or 3 more things. And multiple personality disorders. Sometimes you hear more about that, and then they kind of all go away.
Yeah.
They spike up again. And right now, the transgender thing is really spiked up. And there's going to be a lot of issues coming out of this. And he believes that it's not going to stop until we get lawsuits. There was a place that was doing transition surgeries in the UK. I think it was in London. And they had performed, I think, 30,000, which is, to me, that sounds like
crazy
a
number.
lot.
Yeah, that's a crazy
But they
number.
currently have 1,000 lawsuits against them, and they've shut it down.
Yeah.
They've shut the whole thing down because they realized it was getting out of hand.
Yeah.
Colby, can you look up how many hospital beds are in New York City? What do we find on that if we just look that up real quick? Because one of the things that when it comes to the narrative, you remember when they brought that big ship up to New York City?
Yeah,
because
parked it in the harbor. They had all the
parked
beds,
it in
right?
the harbor, and New York City was flooded, and this thing was so bad, and all of the news stations. I haven't watched news, dude, in years. I grew up Mennonite, so we didn't have TV, so I never got on the TV train. I don't like to watch live news. I like the internet where you can get the news that you want to get, and you don't have to listen to these talking heads ramble. And then there's interrupted by ads. It just feels like you're being catechized by the pits of hell is what it feels like to me. Not growing up with TV. So I don't ever watch news, but all of them were all making this big deal about how New York City's overrun, and here comes this huge ship, and this is a big deal. It rolls into the harbor. Well, you know how many people were served?
I think they treated like one, right, or something. I mean, I know
no,
it was
there was 285 people were treated on that ship the entire time it was there, and it left after like 3 or 4 weeks.
Yep.
The city has 62 active hospitals with a combined capacity of 26,451 beds. So when you go 285 divided by 26,451. I mean, you're talking about an increase in hospital beds in New York City of 1%. I mean, so whether that ship was actually needed, to come up there, or how much of that was agenda.
Yeah.
It's hard to trust now.
Oh,
that's
absolutely.
how I find it. It's hard to trust. It's hard to trust the FDA when they say the types of food you should be eating and how much of which kinds of food. Mm-hmm. I mean, good grief. If I ate the food pyramid, I would feel sick.
Oh, of course.
Every hour of every day.
And so, look, I played this game with my kids a long time ago where, when I would come home, a lot of times what they want to do is ask me like, okay, tell me about your day. Like, tell me what you saw. What did you operate on today? Tell me what kind of cool surgery you did. I just kind of sold my job to my kids as I get to play really high stakes video games, right? With like, I'm kind of like doing laparoscopic
I would think high
right?
stakes. Holy cow.
So I told them, I said, like, I don't get a do-over. If I clip the wrong thing, we've got trouble. So anyway, one of the, I reflect on my day quite commonly when I get home. And today I had the opportunity to see a 30-year-old male who came in with a hemoglobin A1C of 10, right? Floridly diabetic and a testosterone of below 300. So low T by definition, and grossly overweight and type 2 diabetic that is, he's got neuropathy in his fingers at 30 years of age, right? So pretty severe case. I asked him, I said, so what do you think the likelihood is that with medications alone, you can get this problem corrected? And how many medications do you think you would likely need to take to get that job done? Now, those numbers are out there if you won't choose to look them up. But the fact is that most type 2 diabetics will take between 7 to 11 medications, and only 36% of them will actually get control of their diabetes.
7 to 11 medications?
And only a 36% chance of getting control. Only 36% of them will get control of their sugar. Well, of course it is. And so if we look, if in medicine, right, if we sort of look back and we say, okay, well, what that shows you is that we're throwing a bunch of medicines, because if you watch the news, right, then what are you going to hear about? A1C down with Rybelsus. I took this other medicine for my psoriatic arthritis or whatever. It's nothing but a bunch of ads for drugs.
Exactly.
So my point is that we've done really well at adding medications onto people's lives, but with no real impact on disease, no substantial impact on disease, right? So diabetes is one of those failures. We had another failure with the statins, right? We know that was all a lie. That the whole idea of, you're going to lower your cholesterol and lower your heart attack risk. Well, everybody who was in second semester physiology in med school kind of knew that was BS, because cholesterol is not the reason a plaque forms. You form a plaque because there was an injury to that blood vessel first, right? Imagine if you're driving down the road and you see a crew of men patching the blacktop. You don't assume that truck caused the hole, noticed it in the rearview mirror, got out and patched it. The patch is merely the symptom, or the sign rather, that there was something that happened there before. There was a previous event. And so intimal injury, right? The intima is the inner lining of a blood vessel. So the intimal injury, the injury to this very delicate, when you see this, one of the benefits of being a surgeon is that you don't just prescribe medicines, you get to look into the body. You see disease at the real level at which it manifests. So you take this very glistening white substance and there's some injury to it, and then the body responds by trying to put blacktop on it. And that blacktop happens to be made of cholesterol, right? So the scientists naturally said, oh, this is cholesterol's fault. If we lower cholesterol, then we're going to lower the formation of plaque. Well, that doesn't really work, because nobody stopped the injury. Injuries are caused by things like omega-6 fatty acids, smoking, heavy metals. We could talk about a lot of stimuli that can kind of do that. But at the end of the day, that whole statin cholesterol thing was debunked. So now you look at diabetes, cholesterol. Okay, now what about Alzheimer's? We know that a lot of that data around drugs like Namenda and Aricept was flawed, that taking those drugs really doesn't change the outcome of that process at all. I don't know if I could ask, could you just Google for us, just type in type 3 diabetes real quick? I've been talking about type 3 diabetes for probably about 7 or 8 years now. It's really starting to come on the mainstream thing. So look at that first article down below, the little right there. So you can see when it says that NCH thing, right? That's the National Institutes of Health thing. I don't know where we got that at. I think we got an ad there. Go back to the other. Yeah, close that. There you go. Go down to that one right there. So this is a PubMed article. So read that down at the bottom. We conclude that the term type 3 diabetes accurately reflects that Alzheimer's disease represents a form of diabetes that selectively involves the brain and has molecular and biochemical features that overlap with both type 1 and type 2 diabetes. So now you say, okay, well, Alzheimer's drugs are a bunch of baloney. Statin drugs are a bunch of baloney. Diabetes, as we treat it, is a bunch of baloney. The other thing about depression meds, this came out probably last summer sometime. All these drugs that we've been telling people that were working for depression, it really didn't make a difference, right? It really didn't improve their symptoms or lower their rate of falling back into a major depressive episode. So when you put all those, what I would call cataclysmic failures of medicine, and you say, well, then why were they pushing a vaccine, right? So you start to see the agenda is money driven, not benefit of humanity driven.
Yes, that is 100% true. Yeah, actually, that's a very strong point, because one of the things that we can take away from that is the whole thing that happened in COVID then, with the intense singular focus on vaccines after the craziness with the masks and the lockdowns and the social distancing. This was like the third or the fourth step. Like, finally, we got to the vaccines, and then it was just all about the vaccine, and then they're pumping vaccines in everyone, and it turns out to not be working. To your point, this is not a new story. This has been happening in this country. This is just
another chapter in the same book. That's right.
Yeah.
You don't get, so now I'm not surprised, right? Like everybody else is looking around like, oh gosh, you mean to tell me this is like some kind of orchestrated event? Well, look around, man. The other 4 chapters did the same thing.
My understanding is that for Pfizer, the COVID vaccine was by far the biggest moneymaker for Pfizer ever in terms of gross income and net income profits. But the second was Humira. So Humira, I think at its peak was like, or maybe still is, like $20 billion a year. And the COVID vaccines are 36, 40, whatever it is. I don't know what the current numbers are. But Humira was the best-selling drug for Pfizer until the COVID vaccine. Yeah. And now there's some stuff coming out about Humira. It sounds like they were tampering with the system in order to get their patent on that back in 2016, or continue the patent on that back in 2016. Yeah. And man, I have a friend who was diagnosed with something and was prescribed Humira, but couldn't afford it. It was $5,000 a month. It's $60,000 a year.
Yeah.
I'm thinking it's a pill, right? Is Humira a pill? Do you know?
It's an injection, I believe.
It is an injection?
Yeah. I've never actually used it, so I can tell you more about the biochemistry of it than I can about the actual administration.
I mean, they must be making bank on that. I mean, come on. An injection that costs $5,000 a month, you cannot tell me the cost of goods sold on that are anywhere close to... Well, I mean...
Part of the villain in this that we're kind of railing on Big Pharma, and no doubt they need it, right? But the other villain in this is, and I know this is going to probably set poorly with some folks, but there's two other culprits here. The first is an insurance company. So an insurance company is designed to make, I tell people, I'm like, your insurance company makes money off of you when you're well. They make way more money off of you when you're sick, right? So basically they're a broker for services. So who is actually making a lot of that $5,000 is the insurance company, because they broker deals with these pharmaceutical manufacturers that when their patients have this diagnosis, this ICD-10 code, we're going to mandate that our prescribers prescribe this medicine, right? In other words, as Blue Cross, if you have psoriasis, then I'm going to work a deal with Pfizer to say, okay, our first line agent's going to be Humira, right? So patients got to pay so much. We're going to get this much money. They're going to have to pay their copays. And so there's all this money shuffling around that goes on. Now, the second party, and this is where people are going to get upset, is us as the consumer, because we put up with this crap, right? So one of the things that we teach our clients is that you need to use your health insurance like you use your car insurance. Your car insurance doesn't cover you getting your tires rotated and balanced or getting your windshield wipers changed. Those are maintenance things that you are responsible for. But in the event that your car is crashed and you can't drive it, then your insurance is a useful tool. Outside of that, it has very little utility for you. Mm-hmm. So your health insurance should function much the same way. You should have a cash pay relationship with a provider that you trust, who offers a basic level of service, and your insurance remains your insurance, not your daily way to provide medical care.
Yes. Health insurance is really wealth insurance. Like, they're not going to cover much of anything.
Yeah, absolutely. They know the $6,000 rule. No, only like less than 5% of people spend more than $6,000 a year on their health care. So they
is that what it is?
So they set that deductible at that level because that's what
less than 5% of people spend more than $6,000 a year.
It's small, Kent. I know we got a computer genius here, so it's small.
That makes a lot of sense, and because coincidentally, the deductibles are right about
$6,000.
I think the law allows it to be somewhere around $8,000 for individual and $16,000 or something like that for the family, and it's actually a law. But I just heard this comment which made a lot of sense, which is that health insurance is really wealth insurance because it's going to do its level best to not pay for anything that it doesn't have to pay. But in the case, you have a $500,000 bill or something, then it protects the like extreme circumstances. That's right. When it kicks in and has value. Exactly to your point, there's one company that I discovered recently called Crowd Health out of Austin, Texas. Okay. And they are doing a self-pay model where I have an account, I pay membership fees, but that money stays in my account. Most of it stays in my account. And when you need help, I can elect to help you. And when I need help, the crowd can elect to help me. But it's all cash pay. So you get those discounts, significant discounts. Like
absolutely.
What they're doing right now is on bills over $1,000, any medical bill on average over $1,000, they're saving 72%. Yeah, because it's cash pay. It's not insurance. It's crowd funded, essentially
cash pay healthcare.
Yeah, exactly right. Exactly right. I think it's very interesting
It
and
is.
fascinating because we're going to have to break away from the health insurance companies if we want this whole system to change, because it's just too tied in together. And with their 15% mandated net profit margin, that means nothing. All that means is their expenses have to go up, so their 15% profit margin, no one cares about the margin. You know what I mean? Like, you can't walk into the store. You can't buy a jet with margin.
Yeah.
You buy a jet with cash. So who cares ultimately what your margin is? What matters is the amount of money you're making. So if you mandate your net profits that they can only be 15%, okay, fine. Let's jack up our expenses so that our 15% translates into a lot more money.
Bigger, yeah.
And so they have a perverse incentive to have their expenses go up. I mean, the whole thing is like, sometimes it feels like we're pawns in some sort of a game in this country. Do you ever feel that way?
Oh, I think that's, not only do I feel that way, I think a lot of other people are starting to feel that way. And I think that a conscious, mindful individual has to look around and realize that that's probably, at least to some degree, in various aspects of our lives, has already taken place, right? Like, I mean, there are certain things that you are, you're just totally out of your control. And, yeah, I think that most people are starting to wake up to that realization.
Yeah. Did you have Colby Googling something earlier or no? Am I wrong on that?
I couldn't find anything.
Oh, what were you looking for?
It's the percent of people that hit their deductible, the 6,000.
Oh, the 6,000.
Oh, okay.
Yeah,
no,
yeah.
I thought you had told him maybe he found what you.
Yeah, we were talking about the type 3 diabetes thing, and that's
Yeah,
just,
okay.
that's just
So
an
he
interesting
pulled
thing
that up
there,
already.
but
Yeah.
yeah.
Well, phew. I don't even really know where to go exactly from there, because we could dig in like a lot more on any of it.
Yeah.
But on the insurance front, though, are you seeing what's your thoughts on like how to proceed on that front? Are you seeing other plans that are working, or is just something we have to put up with?
I know of some innovating entrepreneurs who are going to be coming out with some products that I think are going to help some people in the marketplace, better navigate this. What we recommend for our clients right now, until we have a better solution, so we have a fairly decent network of providers that we work with that accept cash. So most of our clients elect not to use their insurance. And so if we send them for an MRI or an X-ray, we just tell them this is a cash pay patient.
Really?
And let it go. So I can get an X-ray for, a chest X-ray for $25. I can get an MRI of the low back, the lumbar spine for, $375.
Whoa.
Yeah. I mean, if you pay cash, like what you were saying, right? I mean, because you're removing this insurance middleman, right? Which has brokered all these services and is still making a pretty handsome profit themselves. So when you kind of get out of that, I'll tell you a story. My daughter broke her wrist doing gymnastics. So they call me. They're like, "Dad, I think I broke my wrist." And so she comes home and I look at it and I'm like, "Yeah, it looks broken." So I had an IV bag in the house. So I took an ACE bandage and wrapped her, kind of splintered her hand, and I called a local walk-in clinic. And I said, my name is Dr. Lee Howard. I have a patient who walked in and I think they have a broken distal radius, and I think we need to get an X-ray. What do you guys charge for, a plain film of the wrist, a 2-view of the wrist, and to splint a fracture if it's broken? They said $75. So I said, okay, I'll send the client over. X-ray shows a fracture. They splint her wrist. They give me the films. $75 later, I've got my daughter's fracture stabilized, and I've got films now. So on Monday, I called Vanderbilt Orthopedics. I said, look, I want to see this particular doctor. We're cash pay clients. How do you handle situations like this? So we went in, we paid $300 cash. That it told us basically we're going to take $300. That's going to cover probably your first visit and then maybe some of your second visit. We'll kind of see how it goes. But once we decide what we need to do, then we'll figure out from there. So essentially what happened was they were going to take my daughter to the operating room and do what's called a closed reduction, right? Not make any incisions, just sort of try to set the fracture and then cast it. And so after she was seen by the surgeon, the surgery date was set, which was like the next day or the whatever, a couple of days later. And when we showed up for anesthesia that morning, they had listed her as getting general anesthesia, which should not happen. But when you're maximizing insurance dollars, that's the kind of crap that goes down. We were just happened to be savvy enough to know, like, we're not playing that game. And so we told the anesthetist that we wanted her to be sedated, unless there was some reason by the operating surgeon that she had to be put under completely, anesthetized. So they just did IV anesthesia, like you could get a tooth pulled, right?
Okay.
You know what I mean?
Yeah.
And then, so a lot less cost because we're not intubating somebody, putting them on a breathing machine, going through all this rigmarole, which is not necessary. And so doc comes in, they anesthetize her. He comes in, he sets the fracture, shoots an X-ray, puts a cast on. The whole thing was over in 15 minutes. And we were, I think, I don't remember the exact number. I want to say it was like $3,500, between the bills and everything we got that we would have paid. Now, if we would have went the traditional insurance route, it would have cost us at least $6,000 because that was our deductible for one person, right? You know what I mean? And that whole episode would have probably been more like $8,000 or $10,000, but we would have been responsible for that first $6,000 of that money. So with going that cash pay route, you can save a ton of money.
So do you not have health insurance?
I do. Yeah.
You do. Okay. But in this case, you just went the cash pay route.
Absolutely. And
knowing
I
that it
do
was gonna
that
be
all
way
the
less.
time. And not only that, I maximize my HSA. Everyone out there should get, you should demand that your employer, because one of the things you said was, and the reason why we have to kind of have, get away from insurance companies, the problem is that's tied to people's employment. So I agree with you. I think that is I think we would be great if we could do that. But the problem is that we've got this tied to the employment. That's kind of a hard, it's a hard thing to navigate that. But anyway, if you can demand that your employer offer you a plan with an HSA, then your goal should be to take your pre-tax dollars, maximize that HSA as much as you can. Because when this accident does happen, you've got $6,000 sitting there that you don't have to think about. Right, you can just automatically go ahead and pay that bill, and it's done. And so, maximizing your HSA is and that money doesn't go away; it continues to grow. You can keep it, right? I mean, it's just a great way to save money for healthcare expenditures because they are going to come, right? And you need to be ready for it. But yeah, that's some of the decisions that we kind of work with our clients on.
Yeah. There's 4 million people in America right now that would change their job or do something different if it wasn't that health insurance was keeping them tied in. So it is it absolutely is tying people to their jobs. There's no question about that.
Yeah. Another thing that I believe is absolutely orchestrated.
Yeah, I totally agree.
Keep people in indentured roles.
So what have you seen then with the vaccines? Is it kind of like tomato? We pumped vaccines into a whole bunch of people, which, by the way, the original 2 vaccines, is it BioNTech and is it Pfizer or Moderna? They pulled them now. So there's 2 vaccines where the original vaccines are no longer available. Yeah. And I was looking at some stats the other day, according to those metrics, because they were saying, this was actually from a CNN article that was saying the original vaccines aren't effective anymore. They have made them better. The original ones, there was something like they had like a 1-prong attack, and the newer ones have a 2-prong attack, which to me, I think I'm just highly suspicious. That's just how I am when it comes to like people in power. So I was curious is the new vaccine really that much better, or is it like, all right, we're catching on that the first vaccine was doing some damage, and let's pull that off the market because we have a quote unquote better one now, and that's the talking points but whatever the case, doesn't matter. But according to CNN, they didn't say this. I just deduced 2 bits of information and got to this. Only 15% of the country right now is vaccinated. I mean, they said the first ones don't work anymore, so let's just consider those people unvaccinated.
Yeah.
And only like a few amount of people have gotten the new ones. So right now, only 15% of the people in America are effectively air quotes, vaccinated. And I'm not aware that the deaths are spiking right now. And that's very interesting.
Yeah,
if only 15% of us are effectively vaccinated, we're not having a big problem. And also, what happened to the winter where all the unvaccinated people were going to die?
Yeah.
Wasn't that the winter of 2021?
That's right.
I'm not sure that ever really happened. So there again, you lose credibility.
No, we didn't.
Absolutely.
It was all just that. Again, you must instill fear, because if people aren't scared, they won't take your poison.
Yes.
And that was sort of the whole mentality behind that.
Yeah.
In my opinion.
So is it, like I said, is it tomato with the vaccines? A bunch of people took them. It's all fine. or what are you seeing? Are there real issues out there?
Oh no, there are definitely real issues with the vaccine. Okay, over Christmas, I had 2 people that I know, one of which is a client of mine, and one of which is a friend of one of my children. The client of mine is built like a college running back, works out, is a really formidable guy, right? Not somebody who is just sitting around eating bonbons. And a few days before Christmas, he starts having a pain in his chest. It doesn't go away. He goes in, blah, blah. Long story short, he had a clot in his right coronary artery or wherever it was. But the point is, there was no, in my opinion, looking at his situation, you're not obese, you don't smoke, you don't have out of control lipid levels. This smells bad.
And how old again?
53.
Okay.
The other 53-year-old guy was found dead by his child in the bed. Now, I mean, I'm not saying that those things don't happen, just like young people dying of COVID, right? That happened back with H1N1, and we knew it was going to happen with this too. So that's a sad situation. But it's not unexpected. Mm-hmm. But when you start seeing unexpected rise in 53-year-old men who are dying of what we would call thrombotic phenomenon, right? Thrombosis meaning clot forming, right? And you go back, if you'd ask me, you say, well, what did your protocol, contain when you were treating people acutely with COVID? One of the things that I was very emphatic about, I'm very emphatic about vitamin D, but when people were sick, especially if they were males, I was really, really hard about the aspirin thing. Take aspirin for 6 weeks after you get this, because the thing
after you get COVID?
After you get COVID. Because the thing that was killing people was freaking clots, right? It wasn't there were some people who would get sick pneumonia, get, ventilator dependent respiratory failure and die of multi-system organ failure. Okay, that's fine. That we know is going to happen to a certain percentage of the old debilitated population anyway. But when you take a young guy like you and you say, well, why did this guy get COVID? And then all of a sudden 3 weeks later, he just collapsed on the side of his porch. Well, and they go in, they take you to the cath lab, they suck a clot out of your right coronary, yet there was no major plaque there. I mean, most people at our age, are going to have some disease in their coronaries just because that's kind of how it is. I think there was a study done after soldiers were coming back from Vietnam. So you're taking these kids who are 18 to 22 years of age, most of them, and on autopsy or postmortem, 25% of them had some element of substantial coronary disease, right? I mean, that's a metric I remember. That may be higher or lower than that, but just think about the average being 25%. So if you take the average 53-year-old guy, there's a 25% chance that he's got some substantial coronary disease. But we don't hear about them dying in the numbers that they're dying now. Mm-hmm. And so while I recognize that 53-year-old men can certainly die of heart attacks, the frequency and the pace at which we're seeing it, mm-hmm. when you know what happened to people who got COVID and also got clots, right? So my point is that when we were treating people with COVID, we knew one of the most lethal things that could happen to them, especially for a young man, was to get a clot. And I'll tell you a story. A guy was 44 years old, active with his 5 kids. He's running around doing stuff. He gets COVID, takes ivermectin. He's done in 48 hours. Feels great. Out riding his bike. I'm like, listen, take the freaking aspirin. I don't care how you're doing. Take the aspirin. 4 weeks later, he gets a clot in the superficial vein in the back of his leg. So imagine if that same guy had not taken the aspirin at all. Right? He recovered from COVID in 48 hours. Mm-hmm. But it was this heightened sense of inflammation that he had that caused his body to then form a clot.
Mm-hmm. Was he vaccinated also?
Mm-mm.
No. Okay, so you're telling him to take the aspirin just from COVID.
Right, because COVID was causing people to clot.
Okay,
right? And that was what was causing a lot of heart attacks and strokes.
Okay.
And so so the natural thing was, well, what made COVID do that? Probably mm-hmm. that spike protein, which is so inflammatory to the body, right?
Okay.
So what are we using then in the vaccine? A mimic of the spike protein, right?
Yeah.
So the vaccine is supposed to mimic that, which in theory should translate into a similar response from the body.
Yep.
So then when people are dying of clots, it's not foreign to me. It makes a lot of sense because this is what COVID was doing originally to people, especially young men. And guess who's dying of strokes and heart attacks right now?
Young men.
Exactly.
Well, I heard that, or I saw rather, that 28% of Americans now know someone who's had an adverse effect from the COVID vaccine. Mm-hmm. That's very high.
Absolutely.
I mean,
and that's probably underreported.
Probably. This motorcycle over here,
beautiful bike.
The guy I bought this bike from is still alive, but his best friend had a bike, And these two bikes, this bike and the guy who died, the other bike, have never been on a road trip without each other. And the other bike's a little nicer. And he was 60 years old. He had just turned 60. No issue, no health issues, no pre-existing conditions, nothing. He had plans for his life. He was like within a year or two of retiring. Vaccine, 2 weeks later, dead. Mm-hmm. And the guy that I bought this bike from said he was my best friend. These bikes have never been on a road trip without each other. I don't want to keep this bike. So my buddy bought the other one, and I bought this one. Yeah. But that's like, it's like so tangible for me, you know, like that guy, 60, you shouldn't die unexpectedly at 60.
That's right.
And the fact that the vaccine happened 2 weeks before he died, completely healthy, no priors. It's like, come on. You think that's chance? It's possible. It is possible.
Absolutely. I agree with you.
It is possible that vaccine had nothing to do with it, but improbable.
It certainly smells bad, doesn't it?
Yeah, it's unlikely. I know you had mentioned that you hadn't seen this book, but man, I think it's worth getting. I think I just got this on Amazon. Cause Unknown: The Epidemic of Sudden Deaths in 2021 and 2022. Edward Dowd, who wrote it, was hired at BlackRock. I mean, they're one of the big ones.
Yeah.
And he was a managing director from 2002 to I forget how long. It was over a decade, I think he was there. And his fund went from $2 billion to $14 billion. So they don't let just anyone run a $14 billion fund.
Yeah.
And to run a $14 billion fund, you got to know about statistics and trends, and the economy.
Broader trends. Yeah.
Yeah. You gotta have. They don't let dummies do that.
Yeah.
But you got to be good with numbers, and you have to notice trends. That's how they make their money. So he wrote this book because of the alarming trends in excess deaths. So if you look at excess deaths age 18 to 64, all-cause mortality, it spiked 40% in like a year. And he was saying that in the book, anyway, it says that to go from to have a 10% increase in all-cause mortality would be a 1 in 200 year event. Mm-hmm. But we had a 40% increase. And what's interesting is that increase did not happen in 2020. It happened when the vaccine rolled out. Kobe, can you pull up one of those? Yeah, look at this. This is, even with these reporting, okay, there have been more adverse reactions and deaths reported to VAERS for the COVID vaccine than all other vaccines combined over 32 years. I mean, you can see reports of death, all non-COVID related death, like the numbers are minuscule until you get to 2021 and 2022. And we know even those numbers are probably drastically underreported.
Yeah.
Can you pull up the one that has, it shows the spike in, yeah, look at that. Look at that. So these are COVID-19 deaths before and after mass vaccinations. The one on top happens to be Thailand. And you can see, Kobe, can you zoom in on the date there where it has like that shot? What is that? That's February 24th. Okay, zoom back out. So February 24th, 2021. So until, for those that can't see, here's a chart showing for all of 2020 and until February 24th of 2021, you know, the increase in deaths was fairly low in Thailand. I mean, you can't even see it on the chart. And then after the mass vaccination, it spikes.
Yeah. Yeah, not surprising. I mean, I think that the sort of charlatans who were saying this early, were, as you said, censored, marginalized, discredited. And yet here we are, 18 months later, and everything they said, we're going to see a spike in all-cause mortality. We're going to see rises in cancer deaths that are unexplained. I mean, I had a guy come in with a tumor bigger than a softball in his left axilla, his left armpit. And I mean, this was a really rare, uncommon T-cell lymphoma that had happened. And I asked him, I said, which shoulder did you get the jab in? He said, this one, twice. So the interesting thing is that he had no other disease anywhere throughout his body. None. They could find no other detectable lymph nodes except this one massive lump right here in his arm.
And that happened after the vaccine?
Correct. About 2 months.
Oh my
So,
gosh.
That was like 4 months, I think, on that graft is where the death started, right? When
Yeah.
you sort of started to see that inflection point. But the point is that, that's like, I'm just convinced, man, this is not for everybody. I mean, I know a lot of people who got it, they don't have anything seemingly wrong with them. I don't know what's going to happen in 10 years, but, you have to be a fool to look around right now and not be, this is hurting people.
This is super anecdotal, and I know this is not the best way to approach things, but I have noticed that the people that have been getting, that I know that have been getting the sickest, they seem to have a hard time staying healthy, whether it's from getting COVID again or you name the illness. It's the people that have been vaccinated.
Absolutely. Yeah, no doubt about it. And I think that there's probably a couple reasons for that, right? Like if we look at, there's a thing called study bias, and I don't know if you're familiar with study bias or how much you know about statistics and statistical design, but if we look at guys who are on TRT, for example, there are certain things that that happen to that group. They typically have lower body fat. They typically have a higher lean muscle mass to body mass ratio. They typically will make more money than their average counterparts. The average guy who joins our TRT program will almost double their income in 18 to 24 months. That's a pretty fair statistic that I tell people.
What?
Yeah, guys.
Holy cow. People that come in and get on TRT with you are doubling their income in 18 to 24 months.
It's not me. You know what I mean? That's just what happens when someone is an effective male. You are more confident. You are going to portray yourself differently when you walk into a room. When your testosterone's 1200, you're a different man than when your testosterone's 300.
That is true.
You're just a different man. And maybe it's not 24 months, maybe it's 36 months, but that man over time will be a better lover, a better husband, a better father, a better earner, a better protector for his family. I mean, I can guarantee you that. Because guys who are sticking themselves in the needle or sticking themselves in the leg with a needle twice a week are not sitting around eating bonbons in the hot tub. You know what I mean? They get up and they do hard shit. You know what I mean? That's what they do.
Yeah.
Because that's how you get there, And so you see where the study bias is, right?
Yep.
You're sort of selecting out a group of people who by their default are willing to do things, right, and undertake behaviors that are naturally going to allow them to kind of rise to the top anyway, right? So I think that there's going to be people who will not suffer anything from the vaccine and sort of, be okay with it. And I think there's going to be a crowd who are going to kind of like have some major issues with it. And I think that people who are relying on the vaccine are oftentimes doing so at the neglect of the other things that are way more important in preventing them from getting sick, right?
Oh my goodness.
So in other words, they say like, I'm not going to take vitamin D. I'm just going to take this jab, and it'll be just as good. Well, I got news for you, right? So back in the day, the literature has sort of defined an adequate level of vitamin D as being like 80 to 100. And listen, I get deep in the weeds on vitamin D in my office with my clients, particularly women. And I don't know if Kobe wants to pull this up or not, but you can type in adequate vitamin D levels and breast cancer. And let's just see what pops up, right? Usually on page 1 of Google, there's a really interesting article. It's on breastcancer.org website. And it should be pretty profound. And I share this with women and I tell them, I'm like, okay, so let's look down, go scroll down for me there, and let's see if we can find the breastcancer.org website that has this on there. And in there, it will tell you on their website that...
what if you Google breastcancer.org?
Right there, look at that, breastcancer.org UK. Let's see if it's on that one. So... this is actually not the one. I don't know if it's going to be here. But the point is that if you are so inclined to sit down and do a little bit of digging, what you will find is that if a woman has a vitamin D level of 80 to 100, their risk of breast cancer drops by more than 50%.
Wow.
So the problem is, let's see if it's on here, dude. may still be down there, but okay. So look, they give you this crap right here. Look at this. For example, fair skin types need 10 to 15 minutes. For darker skin types, 25 to 40 minutes is recommended. I ain't never in my life. Okay, I checked over 3,000 people a year. I've never seen anybody get out in the sun and get a normal vitamin D level, ever.
Really?
There's a couple reasons I think this happens. First of all, is that most of your vitamin D receptors are concentrated from like your neck to your knees. So most of us keep those areas covered up. So it's not like you have a lot of vitamin D receptors here and on your hands.
Oh, really?
So even on your arms.
Oh, I didn't know that. I thought it was all equal.
No.
The skin.
It's not all equal.
Okay.
And the other thing is that, my ethnicity is from the northern European continent, right? Germanic, English origin. My ancestors, right, in England right now and in northern Germany, it's January or February. It's freaking cold, right? You weren't getting vitamin D from the sun 40,000 years ago, right? It didn't happen. If you were going to live in northern Germany and you were going to get vitamin D, the most likely source you would have gotten it would be from liver, right, from some sort of animal source. And so I think that people of Caucasian descent need to rely on the fact that their vitamin D will solely be obtainable through a dietary source. Whereas you're Hispanic or black with a darker skin tone and your ethnicity had allowed you to harness that vitamin D from the sun sort of continuously throughout the year, right? And also where it's warm, so you would have been exposed, you would have been naked in the area where your vitamin D receptors were most plentiful.
Yep.
Those populations are more geared to getting vitamin D from the sun, but most of those people are walking around clothed now. It's not like we walk around naked, right? We just don't do that. So the point is that this whole notion that you're going to get vitamin D from the sun is a fallacy. It's, in my opinion, it's something put out by drug companies so you don't take enough vitamin D so you still stay sick.
Oh, geez.
Because the equation here that most people forget is that, so the scale of vitamin D on most labs goes from 30 to 100, right? The assumption there is that a vitamin D level of 31 is the same as a vitamin D level of 91, right? And those two things are not the same. Okay, going 31 miles an hour on a motorcycle not the same as going 91 miles an hour, right? So the power that a vitamin D level of 91 has over its influence of your immune system is far greater than what it would be at 31, okay? So in the past, the literature had defined this adequate vitamin D level as 80 to 100. So if you type in adequate vitamin D levels and you look for what the data shows on breast cancer, and what we're really doing is saying, well, if you have this adequate level of 80 to 100, what's your risk? And it drops by substantially, like over 50%.
Wow.
So that's huge.
Yeah. What do you recommend for males?
15,000 units a day. 15,000 units a day, and then get your levels checked.
15,000 units a day. You're recommending for supplementing with vitamin D.
Mm-hmm.
What is that? What is ml?
Milliliters.
Milliliters. Well, how does that translate to units?
Here we go. This is it right here. Good job there, young man. So it'll be several paragraphs down here. Yeah, keep going. This is basically probably on like page 1 or 2 of Google. So let's see. Go back up there. Yeah. See, this doesn't have a whole thing. There's this. Is it? Yeah. 25% of women said they had adequate vitamin D levels when they were diagnosed with breast cancer. There's another one. There's. Try that one down at the bottom there. That vitamin D, breastcancer.org. Yeah, here we go. This is it. I think this is it. Keep going down for me there. No. Well, I know on my little iPad at my office I can find it, but I mean, it's out there.
Yep.
You can go look it up and you can see it. And then today this young man comes in and I'm like, okay, so here he is. He's overweight. He's got an A1C of 10. His testosterone's 280. I said, so what do you think were the 4, like if you were a male, okay, and you had low or critically low levels of vitamin D, testosterone less than 450, you were overweight or type 2 diabetic or both, and you were deconditioned, meaning you didn't exercise, what was your mortality with coronavirus if you had those 4 characteristics in a man? 99%. I mean, it's just every guy that I went into their house when they got COVID and they got sick and they were really sick, their arms look like spaghetti. Like, when was the last time you did a push-up? Guys are notorious for believing that the absence of medication indicates health.
Yeah.
Terrible mistake.
Yes. Yep.
It's just a notorious thing for guys to kind of lull themselves into that thought that, I'm not taking a bunch of pills, so I must be okay.
Yep.
It's just false.
What are the things that dudes roughly, 20 to 50, I don't know, 25 to 50 what should we be paying the most attention to? So vitamin D, testosterone levels. What's that short list for you?
I think I kind of have a funny little story that I tell because I grew up here in the South, so I kind of feel like I can make fun of my people. And in the South, we have sheds, right? And us hillbillies and rednecks like to put expensive and valuable things in our sheds, right? Our equipment, our motorcycles, our whatever sort of wood, whatever that is that we're storing in that shed is important to us. And I use that as an analogy. I draw out this little diagram on a piece of paper for my clients, and I tell them, you have to take care of your shed. The acronym meaning stress, hormones, exercise, diet, and sleep.
Oh.
So if we can sort of take those 5 areas of your life as a man and focus on optimizing those 5 areas, then 95% or more of what could go wrong with you from a health perspective is taken off the table. So, I do this experiment in the office. I type in it, I get a Google window, and I say, type in testosterone levels and cognitive decline. Type in testosterone levels and coronary atherosclerosis. The data is clear. I mean, it's 20 years we've known that if you get lower testosterone levels, your rate of atherosclerosis is going to go up. If you have a lower level of testosterone, the likelihood goes up that you're going to experience Alzheimer's, dementia, and cognitive decline. So couple that with a carbohydrate-rich diet, and boom, you're a setup for Alzheimer's as a man. You see that?
And most people are doing exactly those two things.
Food pyramid, right? We know go back to like 1960-something when the inverted food pyramid, or what I call the inverted food pyramid, was sort of coined. 60% of our calories should come from carbs, which is a total mistake. And we watched the rate of type 2 diabetes just basically skyrocket after that.
Did you ever see that documentary, Fat Fiction?
I haven't seen that one.
Man, it's so good. It's so good. It's been out for a couple years now. I think you can rent it on Amazon. Oh man, it's a good documentary. It speaks to the fallacy behind this idea that saturated fats, like from meat and eggs, causes high cholesterol.
Yeah, that's this
heart attacks.
Oh, it's such a bad
crazy,
notion, man.
Dude. I mean, again, this is super anecdotal, but in April of 2020, I went on the carnivore diet from April to July. Going into that, my cholesterol was high per the blood work, and I was pretty carnivore only for probably a month and a half. And then on the back half of that, I started to loosen up a little bit, but I still considered myself on carnivore from April to July. Longest I've ever been on carnivore. I've done it for like a week or 2 here or there. I've been on it now since January the 11th, and man, I feel great. But April through July, and I got my blood work again. My cholesterol was high going in, and by the end of it, it was perfect. All of my levels, every single one of my levels by the end of that carnivore stretch was dialed in perfectly.
Yeah.
So
I see it hundreds of times a year. Hundreds.
Really?
Oh, absolutely. If you can, if you
with carnivore or protein heavy diet.
Well, so here's what I tell my clients. Okay, if you look at the Earth, right, and you take the North and the South Pole, and you say, well, what those sort of represent the climatic extremes of our ecosystem. What happens in those environments? The answer is not much. It's uninhabitable. As a general rule, nature doesn't reward total extremes. Okay? In other words, a zebra born with 0 stripes has a much greater disadvantage than a zebra born with only 50% of his stripes, right? Mm-hmm. So as a general rule, nature doesn't reward total extremes. So what I encourage clients to do is to take a paleo kind of carnivore philosophy to things, right? That there's some mixture of fruits and vegetables and a lot of clean, saturated fat, animal protein that's good stuff, and some combination of fruits and vegetables with that. So what I know is that if I eat about maybe a couple of cups, 3 cups, maybe as many as 4 cups of vegetables a day, typically like shredded cabbage, broccoli, diced cauliflower, or something like that. And then the rest of my meal is protein or an avocado, and I eat sweet potatoes too. And so, I can literally eat a pound of meat and an avocado and a little bit of sweet potato, and I feel like amazing.
Yeah.
Yeah. And so from my perspective, that's sort of how I see carnivore, is that it's heavy in the meat, and I don't cut the fats out, dude. I cook it in duck fat, I cook it in beef fat, and I eat that, and it's good.
Yep.
Right. And so from my perspective, I know that I got to incorporate a little bit of vegetables because I just digest better. I poop better. I feel leaner. And overall, it just works better for me. So I try not to move towards the extremes.
Yeah.
I try to find something close to that.
Yeah. Makes total sense. Okay. TRT and HRT. Is there a difference, or is TRT a subset of HRT and HRT is the broader definition? What's the difference?
I think that could be nuanced, really.
HRT being hormone replacement therapy.
And TRT obviously just referring to the testosterone part,
Yeah.
right? Well, so for females, this equation is different, obviously, because they've got more, sort of pieces on the chessboard than what we do, right? In terms of hormone pieces that they can move around, because they got estrogen and progesterone. Males have those too, just to a much lesser quantity. And the opposite is true for females, in that they have testosterone, they just have a much smaller quantity, right? On average, women probably have like 10 to maybe 5 to 20. We as men have 5 to 20 times testosterone is what our female counterparts have. And so, but here's the interesting thing, Ken. The biological actions of testosterone in men and the biological actions of testosterone in women aren't any different. So testosterone is responsible for helping all of us maintain our muscle mass. Testosterone is responsible for helping both sexes have a libido. Testosterone is responsible for helping both sexes overcome stress and overcome injury. That's what testosterone does, right? It's your body's major natural anabolic.
Testosterone is the libido function in a female also?
Absolutely.
No way.
Absolutely. Absolutely.
I didn't know that.
And so, look, of course, and I spend a lot of time, I shouldn't say a lot of time, but I place a lot of emphasis on a healthy sexual relationship between a power couple, because what I've seen is that maintaining that and placing emphasis on that leads to a lot of good things as that couple ages, right? They don't grow apart. They maintain their earning power. They typically have happier lives with their kids, right? So I've seen a lot of good things come out of focusing on that intimate relationship. So that is something that we talk about a lot with my clients. And so I tell women that, like, look, you've been taught all your life that estrogen and progesterone are so important to you, right? And I know this is going to fall in the face of some people, but women actually do need estrogen and progesterone, and it makes them uniquely female. I don't care what kind of craziness we're trying to be onslaught with right now, but the fact is that makes them have periods, that makes them get breasts, that makes them be able to conceive a child and then birth that child and then breastfeed that child, and that's what makes them uniquely a female. But testosterone has nothing to do with that. Testosterone doesn't make a woman get her menstrual cycle. The only thing it does is give her a libido, right, when it comes to reproduction stuff. Okay. Everything else is done by estrogen and progesterone. I mean, we could talk about prolactin. There's going to be somebody out there that'll listen to this and be like, well, what about prolactin? What about oxytocin? Sure, those things are important too, but in terms of dominant players, they're certainly not that. Testosterone is by far the biggest guy in the room. And so your question about, TRT and HRT, I look at HRT as a broad category of how we balance hormones across both sexes. In men, the focus is on testosterone because of the major role that it plays in us. It plays a major role in our female counterparts also. They just need a lot less of it.
Okay, that makes sense. I had a friend, he's in their probably low to mid 60s, and I was telling him about my experience because I went on TRT of May of 2022.
Okay.
And total T was like 342, and free T was 7.41. And by August, total T was over 1,000, and free T was 26. And dude, I felt great. I mean, I haven't felt that good in a long time. I was hoping I would feel that way through the winter, but October, November, I definitely had a drop off just in how I was feeling and my outlook and clarity of mind and everything. But I just don't like the winter, man. I don't do well in the winter. Going into the winter for me is always a bit of a downer. I don't know exactly why that is, but I felt like $1 million last summer, man. And so I don't plan to stop. I don't want to stop and go back to the way I was feeling before I was on TRT.
That's right.
So I was telling this guy about my experience with it and wondering if he knew, because he's in his 60s, if he knew what his T levels were, and he didn't. So he got him checked. Him and his wife, they both went in and got him checked, and so they started on it. And she's on something too, and I don't know what it would be exactly. There's testosterone in it, but I'm not a doctor, so some of the stuff like grosses me out a little bit. But he was saying like she's postmenopause and a lot of like vaginal dryness, and he said 2 weeks in cleared that all up.
Oh, absolutely,
completely gone.
Yep.
He's like, I don't know why he didn't hear this sooner. He's like, they're going to be on it the rest of their lives.
Yeah, that's probably so dryness is more of an estrogen equation for a female.
Okay.
Right? Like so dryness, skin dryness, joint dryness, vaginal dryness are all secondary effects of low estrogen.
Okay.
And so one of the sort of I think issues that people get hung up on when they talk about hormone replacement therapy, especially women, right? And this is for good reason, so I'm not trying to like say it's stupid or whatever. We have been taught, medical doctors have been taught that hormones are influencing the development of cancer. Specifically, we talk about this in breast cancer, right? ER positive, PR positive, estrogen receptor positive, progesterone receptor positive breast cancers. And you know, when I was a kid growing up, and even in my younger years of medical school, when you went in to an oncology unit, it was unlikely that you would see a young female there with a gynecologic malignancy like ovarian or uterine cancer. And now I think, you know, the percentage of females in these oncology units that are young and having reproductive malignancies is increased pretty substantially. And in my opinion, we're being told the wrong thing. We're being told that it is a woman's native estrogen or progesterone that is contributing to the growth of these cancers. And I don't really think that's the case. My suspicion is that we started to put women, young women, who are eating a really crappy diet, and that's causing them to have even more of an estrogen imbalance. Like 95% of women have a pattern called estrogen dominant anyway. Okay, so they're going to have a surplus of estrogen to their relative balance of progesterone, and so this pattern is so predominant, right? And so you take these young women who are eating a poor diet, they're already estrogen dominant, they start to have bad, crampy menstrual cycles, they have a relative deficiency of progesterone, and they take them to the family doctor, and the family doctor says, oh, here, you need to take this oral contraceptive pill. So they give them something like, I don't know, let's just make it up. Let's call it levonorgestrel. Maybe they put an IUD in, or they give them some other kind of unnative hormone. Now, this experiment was done before. It was done with a drug called Premarin. You familiar with Premarin?
Nope.
Okay. So we can look up Premarin. We can find out what it came from, but I won't bore you with the story. Premarin boils down to pregnant mare's urine. Okay, so we were taking pregnant horses, having them pee in a vat, boiling this water off of it, then taking the equine estrogens, which are not native to a, Homo sapien female body, putting them in women, and when they got strokes, blood clots, heart attacks, cancers, we said, oh my gosh, hormone replacement therapy must be bad. Well, no. It's that hormone replacement therapy with hormones that are not native to the system causes bad problems. Sort of sounds like a birth control experiment, doesn't it? Mm-hmm. We're using non-native hormones to control physiology. So what I think happens is not that native estrogen and progesterone are stimulating the growth of these cancers, but when you take a product like levonorgestrel, what I want to know is what 10 things is levonorgestrel broken down to by the liver, and then what are the subsequent biological actions of each of those byproducts? And that's a discussion that nobody really wants to have. Because to me, if we look back at the Premarin experiment, right, and listen, we just did this with the whole COVID dialogue, right? We just sat here and talked about how you look back retrospectively and this smells bad. So this smells bad to me too. So I don't advocate for hormonally based contraception in young women. I just don't think it's a good idea.
What would be that? The pill?
The pill.
The pill?
Yeah.
Okay.
Yeah. Or an IUD that's a hormonal based IUD.
Oh, okay.
But going back to your question, which was, hormone replacement therapy versus testosterone replacement therapy. Obviously, TRT applies specifically to the testosterone component of that. Yep. But hormone replacement therapy, in my opinion, could imply a broad sort of group of interventions meant to, sort of stabilize the hormone patterns in people.
I see. That makes sense. It seems like they should come up with. It seems like it got a kind of a weird name. Like it's not that self-explanatory. Testosterone replacement therapy. Like I misunderstood it at first. I'm like, oh, what? I don't want to replace what I have. Like.
Yeah.
But once I understood, it just seems like the name is not that self-descriptive. Okay, NAD, which is how I found you to begin with the buddy from the gym. What does that stand for, by the way?
Nicotinamide adenine dinucleotide.
Holy cow!
Yeah. So it exists. It exists in way more forms than just NAD. There's NAD. There's NADH. There's NADPH. There's NADP. There's a lot of NAD. I don't know. I wish we could draw here to sort of illustrate something. But basically, think of this mitochondria. When you look at a diagram of a mitochondria in the book, you know how they had that little squiggly line sort of going down through the middle of it? Mm-hmm. Well, the reason it's diagrammed like that is because conceptually what that represents, if you were to look at like a scanning electron micrograph of a mitochondria, is this organelle inside the mitochondria called the inner mitochondrial membrane, or the inner cristae of the mitochondria. And basically, this represents a series of chemical chain reactions where, A plus B equals C plus D equals E plus F equals G, and this sort of moves down the path, with the ultimate outcome being the generation of a compound called ATP, adenosine triphosphate, which is then broken down through another reaction to yield energy, right? That breaking of that bond of ATP to ADP, adenosine diphosphate, is what releases energy. And so when you look at that sequence of reactions that occurs along that mitochondrial inner membrane, there are a lot of cofactors, right? A lot of sort of external parts that sort of play into that system to help it move down its desired path, okay? And so NAD is one of those major currencies, right? It's one of those major components that help drive that energy production process forward.
Frequency or frequency or currency?
Well, we're not talking about an electron wave that has both, right?
Okay.
Or like a sound wave that has both amplitude and frequency and that kind of stuff, right?
Okay.
What we're talking about is if you had to make cement and you ran out of water, you ain't making no cement.
Uh-huh.
So my point is that if you're trying to make energy and you don't have enough NAD,
gotcha,
then you're losing one of your key components,
gotcha.
right? And we know that NAD is one of those things that we can A, administer intravenously, B, it gets depleted as we get older, so we know conclusively that this declines, much like our testosterone and other hormone levels do. Now this is, to me, this is interesting, I guess, because I'm a nerd. But what happened is that, so the mitochondria is a really unique structure. Like there are people who just dedicate their whole entire careers to studying the mitochondria. And I mean, it's really interesting because, so you got a cell, and each cell, like a cardiac myocyte, a cardiac heart cell, could have maybe 400 mitochondria in it, maybe more. And so each one of those mitochondria has its own DNA inside of it. Right? The mitochondria is the only organelle inside your body because it lives within a cell. So a cell has its own DNA, but within that are these mitochondria which have their own DNA. So we won't have to get into the science behind it, but it was hypothesized that sometime millions and millions and millions of years ago, the mitochondria was actually an externally living organism that was then engulfed by like a regular bacteria or a regular cell.
Oh,
and then it learned how to take this energy production and make it work for the cell itself, right? You see what I mean? So that's the only sort of logical path, or one of the logical paths that could have been taken to why it would still have its own DNA. So it's unique, right? It has a lot of unique characteristics about it. And so probably like 2018, maybe 2017, I was dealing with some people who were having what I would consider chronic neurodegenerative issues, multiple sclerosis, Parkinson's, things like that. And I started to think about, why is it that there is this undercurrent of physiology that happens, right? These people, no matter what you label their disease, they have a very sort of scripted path at which their disease unfolds. And we sort of label them differently, but at the end of the day, the outcome's kind of not really that much different. And they have different symptoms, but they kind of overlap and so forth. So in med school, we're taught that there's these viruses like human herpes virus 6 or HHV6 and chlamydia pneumonia and Epstein-Barr virus. This has been now conclusively linked to multiple sclerosis or MS, right? If you have Epstein-Barr virus, which 96% of the people who do, and then you have a higher, 20% higher likelihood of developing MS. Okay, so we know conclusively that these diseases can affect neurologically your the outcome of your body. So the path that these viruses take is, but by invading a cell, they sort of go into the factory and then hijack the factory to make it do what these viruses want it to do, right? Which means that they probably also affect the mitochondria, right? And so I started to think about, well, what if I was able to treat the mitochondria in these people, and how would it help them get better? And so I started using NAD in this population. Traditionally, NAD had been used in addiction. It got a lot of talk back in reducing recidivism and people who were going through addiction withdrawal. And
Really?
yeah, that's sort of, it was only been an anti-aging treatment for probably the last, 8 or so years or something like that. But,
Oh, wow.
But traditionally it was used in addiction recovery. They would hook people up to an 8-hour drip and sort of just let them sit there. And the point was that it really cut down on the likelihood that they would, rebound or go back to using drugs. I don't know the numbers, but they felt like it was good enough. But it's only been in the last 7 or 8 years that it's been accepted as an anti-aging treatment. But the point was I started using it in these people, and I saw that they had clinical improvement. They got stronger, they had more mental alertness. They were able to have better coordination in their limbs, and so it started to make sense. And then fast forward to now, like September of 20, I told you that's when we started seeing some of the long hauler stuff. Mm-hmm. And so my hypothesis was the same. My hypothesis was that COVID has screwed up the mitochondria just like HHV6 or chlamydia pneumonia or Epstein-Barr did. So if I started using NAD in my long haulers patients, is that going to help them get well? Now, look, you take a guy like you and me and Kobe here, and we go in, we get NAD, we're going to feel better, no doubt about it. It works. But in these people who have some sort of chronic issue, I really believe that the mitochondria it's what we focus a lot on it in our practice. Put it that way. Mm-hmm. And I only do it in well people too. I should say. If I'm dealing with a fighter who or somebody who's got some other desire to compete at a high level, what those people really want is power on demand. Yes. Right? Punch as hard as I can, kick as hard as I can, run as fast as I can, that kind of stuff. So from an athletic standpoint, what you're really looking for is that when you call on that mitochondria to make ETP, that by George, it's ready to go right now.
Okay.
So you see how priming it with NAD makes sense, right? So what I did was I put together a whole supplement protocol, because I told you in the beginning, I said this is basically, NAD is one of those things that moves that energy production process forward. There's a lot of other things that fill into that. So what we do is we've developed a protocol that allows us to use NAD, but then we're also feeding your mitochondria other things to help drive that process forward and make it even better.
Like what?
CoQ10, riboflavin, pterostilbene, ubiquinol, things that you can find in most methylation supplements.
Mm-hmm. And there's mitochondria in the brain also, correct? Mm-hmm. Yeah. Did you hear of the book Brain Energy by Chris Palmer?
I have not.
He was on Tim Ferriss's podcast. That's first how I found him. And he's kind of having his, he's kind of blowing up right now a little bit in his own way. I forget where he's from. I think New York City or New York maybe. But he wrote a book called Brain Energy. And the premise is basically that diet has a lot more to do with depression and anxiety and poor mental performance in general than most people ever thought. And particularly he's interested in the keto diet. Mm-hmm. Apparently the keto diet has been prescribed for people with seizures. For 60 years. Really?
Absolutely. This was pioneered at Hopkins in the 60s. We were treating kids with refractory epilepsy with a ketogenic diet with great success.
That is fascinating.
That's been around for 60 years. So that's what I tell people. I'm like, so you come in with a neurological disease, and so a lot of people will come in and tell me, they're like, oh, I was recently diagnosed with Parkinson's, so I went to this nutritionist, and they told me that I need to be on this all natural, plant, fruit, and vegetable diet, right? Because it's good for my body. I said, well, that's not necessarily an untrue statement, but let's think more clearly about what your issue is here. Are you looking for a diet that's good for your body, or are you looking for a diet that's best for your brain, which is the disease organ that you're currently trying to treat? Those two things are not the same. So going to a nutritionist being told you need to be on an all-natural fruit and vegetable diet when you got cancer, well, is that diet necessarily the diet that helps me fight cancer? Because those don't have to be the same thing.
Right. They're not always the same
That's
thing.
right. They're different philosophies. You're not doing a diet that's good for your body. You're doing a diet that's bad for cancer. And that's a different approach.
And so that's where this whole thing of mitochondria health had first popped up on my radar. I just didn't know that much about it. But that's the premise, is healthy mitochondria, healthy brain, less diseases.
Absolutely.
So you're using NAD treatment for people with some of these autoimmune diseases and issues, but you can also use it to optimize performance, like with fighters. And then do you recommend it at all for like regular people like me?
Oh, absolutely.
You do?
Absolutely.
Okay.
And no doubt about it. I mean, think about it as if you had bought a car, and your car, you said you're 40, right? I'll be 47 here in a couple months. So, I got a 47-year-old automobile that I'm driving around, right? And it would be foolish for me to think that I had the same fuel efficiency and gas mileage and sort of overall, acceleration and things that I had from 20 years ago. So if you want to be optimal, right, and I want my machine to be optimal, then I've got to run better gas in it, because now that matters, right?
Yeah.
20 years ago, it didn't matter.
Yeah.
I've got to make sure that I give it some adequate rest. My point is that becomes part of your armamentarium to stay well, right? So if someone's coming to see us, our advice is that, every 6 to 9 months, they're going through an NAD protocol, a mitochondrial rejuvenation protocol at our clinic. And that can be accelerated, or the intensity can be increased if something happens to them. They fall, say you go out and you rupture your Achilles. Now you got to have surgery, right? Well, now that reserve that your mitochondria had has probably been exhausted throughout the storm of this surgery and this injury. And so depending on sort of what happens to you, it can be slightly different.
What about a back injury at CrossFit?
I mean, are we talking about something that,
Like a bulge disc?
So I think
that's
that
something different.
No, it's not necessarily different. What I think what you're asking is that at what magnitude of injury do you start to worry about this ripple effect? Is that kind of what I'm getting at?
Yep, that's well said.
And the answer is that you can't tell, because I don't know where you're starting from, right? Let's take another example of this. Let's suppose that we're two soldiers going into a battle. Why is it that one of those soldiers could come back with PTSD and one of those soldiers may not? They experience largely the same set of circumstances. What was it about their perception and how that perception affected their body that then permanently changed them? And so when I was in med school, one of the professors told us, they said, when we decode the human genome, we're going to be able to unlock the key to, so many diseases. And a couple of us turned to each other and were like, no, not really. It's not going to happen that way. Because of this concept called epigenetics. And what epigenetics says is that, let's say we had this long, DNA code written out here, right? So we can look and we can say, well, with this sequence of amino acids, or this sequence of purine and bases and stuff, that this is going to code for this gene, right? Well, that's good to know, but you also need to know what factors control expression of that gene, okay? So, for example, you can have a trait for blue eyes, but brown eyes are dominant, and so therefore your blue eye trait won't be expressed. So that is an area where an epigenetic expression suppressed one gene for the sake of expressing another. So if you and I were standing in the street and we watched a toddler get hit by a car, within a split second, our body would start to synthesize chemicals to, force us to go into action to help that child. At some point, those signals must be turned off. Okay? Those signals to activate and express DNA must be turned off. When they're not turned off is when you get things like PTSD. Right? It's when you can't turn that switch off, when you can't reverse that genetic expression, that things start to go off. So you take somebody with a minor back surgery. You guys have no idea how many times I see this. This is just it is uncanny as to what happens. And I'll give you an example that happened recently. This kid came to see me. I can't remember. He's 30, 32. He comes to see me. He's accompanied by his mom. He's in a wheelchair. His hair's long and scraggly, and he's got dandruff flowing through his hair, and he's got these flip-flops on his feet, and he can barely kind of scoot along in his wheelchair, and he's just not well kept. So his mom comes in, they sit down, and we start, he won't talk. He kind of has a funny position that he's holding his arm in. And I asked his mom, I said, well, how does he communicate with you? She says, well, he only texts me. Why does he only text? Well, he doesn't like to talk because he gets out of breath. I said, okay. Well, if his arm is constantly bent like this, how does he text? Because that arm doesn't seem to be working pretty well. Well, I don't know. He can do it. Okay. As I dig deeper into this story, you find out that they were there because they thought that he had Lyme disease, right? And the Lyme disease had deteriorated his body neurologically to the point where he was now confined in his wheelchair. And so as I start to get this interaction between the mom and her son, I started to realize that this kid is playing his mom. That what's going on here is that he doesn't want to talk, because when I start to ask some pretty deep questions, things that I knew would probably piss him off, he was able to talk just fine. And so I'm like, you're able to talk now, but you won't talk to her. And so then it starts to come out that the family sort of had this suspicion, right, that he could probably do more than what he was doing. Well, we've heard other family members say similar things. We've kind of, tried to talk to him about this. And so as I had started to dig deeper, I said, so, this all started after this accident that you had. You had this accident when you were like, well, I don't know, 26 or whatever years old. And it was after that accident that you spent 2 years in bed. That is what caused this. We could park an ultrasound machine down at the stoplight down here, and we could ultrasound a lot of people's abdomens. We'd find gallstones on a lot of people, but it doesn't mean everybody needs to have their gallbladder out. So just because you check a Lyme test on somebody and they got Lyme disease or Lyme proteins in their blood doesn't mean that it's causing them to be confined to a wheelchair.
I see.
See what I mean?
Yep.
Those two things can be true at the same time. And so in this young man, I said, look, it doesn't make sense. Like basically for the last 6 years, you haven't done anything, right? So if you got Lyme disease, you didn't get it in the last 6 years because you ain't been outside. And so you must have had this before. So whatever they found in your blood, you probably had before 6 years. And so what could have happened is that this event that happened triggered something from an epigenetic standpoint that has now caused your body to go down this path, much like a PTSD would have happened in a soldier. You see?
Yep.
So I told the parents, I said, look, we could spend $25,000, quote unquote, treating Lyme disease. It's not going to fix him. He's got to get over this up here. The fact that he had this accident and what it did to his body is the problem that he's never let go of. And there's no amount of medicine on the planet that's going to fix that. And I see this, you guys, I see this so often. I mean, I could tell you story after story of people who come in and tell me they haven't been out of the bed in 2 years. And I'm like, well, I can tell you there's no physiological reason for that, right? In other words, if this building caught on fire, you ain't going to lay there and burn to death. You will drag yourself out of this building. You know what I mean? Like, you'll get out of here. You can if you want to. And so many people who have had an event happen to them that has permanently changed their life. And sometimes it is absolutely trivial. So when you ask me about a back injury, well, I don't know. I mean, what if this back injury caused you to lose your erectile function for 6 weeks? Could that then have a substantial, long-lasting impact on your psyche for the rest of your life? The answer is yeah. I've seen it happen.
Would some of those cases be potentially helped with certain psychedelics?
Wow. I mean, so I believe in the power of psychedelics. I'm very open to the fact that I think they can do things that not a lot of other therapies that we have can do. I think the biggest determinant of whether or not someone can move through that dimension or move through that dynamic is not necessarily the therapy they employ, but how much they want to achieve the outcome.
Oh, okay. You see that as like the biggest determinant factor.
Yes, because so many of these people are tied to their disease. Their entire existence is now defined through their debilitation. And the help that they've been able to garner and the sympathy that they've been able to garner, right? And the sort of comfortability that they've built around themselves with no responsibility. So many people don't want to break through that.
Yeah, that makes sense.
You start getting them well, and guess what they don't do? They don't come back.
Yeah.
I've had more than one person be like, well, I was transitioning from my wheelchair to my, to my toilet. Now I can do that. And then they stop coming because now they nobody's coming to help them.
Oh boy. Wow. That actually happens, huh?
Human psychology.
There's a term for that where you like want to go back to your captor, right? What is that term? That's a thing. It's
a thing.
When you're taken
exactly
into
right.
captivity and you want to stay there, or you want to return to
Yeah.
it. It's kind of like that, it seems like. Well, what do you think is the utility for psychedelics in modern day, in our modern day, I guess? Is there ones in particular that you think have more usefulness? What do you see as some of the use cases or benefit of psychedelics today?
I think there's probably two sort of broad categories to break that down into. I think there's sort of the microdosing aspect of that, and then there's what maybe some would call the therapeutic dosing of that, right? I think that microdosing, especially with things like LSD and psilocybin, I'm not so much sure about. I don't have a lot of background in like microdosing MDMA or some of these other DMT or some of these other things. So I think that if you're talking about microdosing like LSD or psilocybin, and we talk about some of the cognitive enhancing benefits that can be seen at these small doses, sort of periodically, or even consistently for a few days over weeks, I think that those are real, and I believe that the use of that therapy will gain traction, because kind of like hydroxychloroquine and ivermectin, it has a very small risk profile and a very large potential upside.
Yes, and aside from LSD, I don't know that you can patent psilocybin, right? At least you can't patent the mushrooms.
No, yeah, that's right. The chemical would be
if
natural.
Pfizer does patent mushrooms, you can just go grow your own.
Go grow your own, yeah.
So there's not an industrial sort of economic incentive here, which could be part of the reason why it's not more popular than it is.
Well, except for the fact that drug companies are pretty smart, right? And so what they'll do is kind of like what they did with this drug. It's for epilepsy. Golly, I can't believe I can't think of it. But basically, they took a CBD, kind of like isolate, and then they got it. It's called Epidiolex. That's what it's called. Epidiolex is a cannabinoid. I don't know what to call it, an isomer maybe, or a terpene. Sort of like a specific sort of part of CBD that they were then able to get approved. The drug company were able to get approved for use in epilepsy and controlling epileptic seizure disorder.
Okay.
So they can kind of bastardize this, right? They could take psilocybin and say, well, we want to take this portion of the molecule and formulate it in a way because that's the most biologically active part, right?
Oh boy.
So yeah.
So
I wish I could tell
that.
you. Yeah. I wish I could tell you they did it with ivermectin, right? They basically Merck came out and came up with a new version of ivermectin.
I forgot about that.
Yeah. So they'll they'll play funky chemistry games. You know, they're either going to change the nomenclature, right? How you name something, just like they did. Oh, it's not a recession. Oh, it's not, you know, it's just like changing the names to suit their purpose. So I'm not really.
Yeah, that was another sort of point of revelation when this thing that wasn't supposed to be helping at all or maybe even harmful, ivermectin, when Merck figured out a way to patent a piece of that and then they were selling that. Yeah. Everyone was fine with that. I wanted to ask you about peptides.
Sure.
What's the scoop on peptides? I don't understand them at all.
Okay, so think of your testosterone like this whole big box, right? This box has a top, it has some sides to it, and it has a bottom, right? So we could deconstruct this box, and maybe if we took this part off, it could serve another purpose somewhere else, right? So think about this like a big hormone, would it be like a testosterone? But if we took just this piece, that is now a peptide. It's a smaller part of a bigger structure. But this has a specific function. It can't contain anything, but it can cover this, right? So a peptide is a small protein that has a more specific biological function. A hormone typically is going to affect the whole system, whereas a peptide tends to be more specific in its action. So testosterone affects every tissue in your body, right? Whereas a peptide typically is going to affect only certain parts of the system. And so peptides tend to be more specific, and they tend to be very focused in their application.
And that's why you can use different peptides for different uses.
Correct.
Okay. Man, how far we've come. My goodness.
It's going to get better.
Yeah?
Oh, yeah.
Like what?
Well, I mean, I think that there's going to be, okay, so we don't have a lack of options to treat people with things like peptides. What we have is an issue with production, with certain regulatory bodies allowing people to do things, right, to make things. And this goes back to kind of one of the things I glossed over earlier, which is about the sort of something needs to be proven to be both efficacious and then not have harm at the same time, right? So let's say you're talking about something like, I don't know, like BPC 157 for healing an injury as an anti-inflammatory. And let's say that I own the patent on BPC 157 and you own the patent on diclofenac or Toradol. And we do a head-to-head study on high ankle sprains in young soccer players. So we take these 20 kids, you give them diclofenac, I give mine BPC. We measure the days that they come back, their pain scores, who gets back to the court quickest, who had lower pain scores, who had lower inflammatory markers. We could measure a bunch of stuff. The point is we gather data and then we try to prove our case. You try to prove that diclofenac was superior by getting these people back to court earlier or back to the activity earlier, and therefore it must have healed the sprain better. Their pain scores were better and so forth. So I come in with BPC and I say, okay, here's my data, same metrics. We measured the same types of, outcomes or the same type of what we were studying. It was the same, the variables. And so if we were talking to some regulator, some idiot in Washington, some senator or something, you could probably sit there and say, well, Mr. Senator, my product showed that we got them back to the court 10% quicker. And therefore, you need to approve our drug to be for high ankle sprains, it needs to be getting approval for that. Mm-hmm. Well, and their number was only 7%. Ours was 10%, okay? Well, what they didn't tell you and what the regulator didn't ask was, what was the incidence of side effects for your diclofenac? What happened if they took it for 6 weeks? What was the incidence of interstitial nephritis or ulcer disease? Nobody asked that question. What was the amount of harm? All you focused on was the amount of good that you can do. So the regulators aren't smart enough to say, well, okay, fine, maybe you had a better 3% higher rate of getting them back, but your incidence of complications for people who had to take it longer was much higher. And over here, yes, this was only 7%, this BPC was only 7%, but basically there were no complications with this, right? There were no downsides. There was no gastritis. There was no interstitial nephritis. So at what point does 7% with no risk of side effects become less good than 10% with potential side effects?
Yep. That makes sense.
And regulators don't ask that questions. Again, you got people making rules about shit they don't know nothing about. You know, they don't know to ask these questions. And so to me, there's going to be more of an acceptance of this. This is going to start to be legitimized. The fact that people know now that there is an alternative. And I think there's going to be more of an outcry to make it available.
Peptides?
Correct.
And what would they be an alternative to?
Well, if you take something like BPC, you're talking about basically NSAIDs.
Okay.
So Toradol, diclofenac, prednisone in a joint, you know.
Gotcha.
Now, I obviously, prednisone is not an NSAID, right? Prednisone is a steroid, but, you know, NSAIDs being diclofenac, Toradol, that kind of stuff.
I see. Okay, so there's a lot of different use cases for peptides, and we're just at the beginning of what these things can do for us.
Absolutely. Yeah. As we're able to manufacture them more and apply them more, we're going to come up with more uses, you know?
I mean, there's peptides that make your face, the skin on your face better, right?
Yeah.
Like that's specific.
Yeah.
Fascinating. So,
Well, I mean, something like GHK copper, right, which is typically thought of as an aesthetic peptide treatment, can also be used in other ways, you know? So you can use GHKQ, you know, with a lot of different applications, but it has a great, you know, sort of following from the aesthetic market.
what do you think is one of the most underutilized practices, things that are at our disposal for flourishing for the modern American male, you say?
The way you eat. In my office, I have a diagram of a pyramid. And on the bottom of that pyramid, it says diet. And the second rung of that pyramid, it says hormones. And then there's 4 or 5 levels above that are blank. And I tell people the story about, because I'm left-handed, so that kind of makes me a little quirky in some of the ways I see things because of the way my brain is connected. I'm also very ambidextrous. I would prefer to write with my right hand if I'm writing on a board or something. So I tell people that, look, when I drew that diagram, I wanted to put the longer word on the bottom rung of the pyramid because it made it look symmetrical to me. Mm-hmm. And I sat there and I thought about this, right?
I would totally care about that too.
Yeah, I was like, this looks like the longer word, right? It should fit there and it looks good. And then the second thing, a smaller word, it looked great, right? And then I put it down and I erased it. And I was like, but that's wrong. That is absolutely wrong. It's wrong because the diet influences everything else, right? In other words, if your diet is shitty, it's much harder to balance your tea. If your diet is clean, balancing your tea becomes easier, right? I mean, so the diet influences everything else, not so much the other way around, in my opinion. So I believe that the first thing that you have to master, if you're going to spend money on your health, it needs to be on what you're putting in your mouth. Because if you do that, so many other things will start to work well for you.
Mm-hmm. If someone eats clean, like myself, until 8 o'clock at night, and then has a habitual problem with snacking, how detrimental is that?
Terrible.
Oh, jeepers. That was not the answer I was looking for.
It's terrible. It's terrible.
I'm talking like, pretzels, maybe some chips, some chocolate, nothing crazy. Come on.
So I think it's not socially conducive because nobody really in the modern world kind of does this unless you're one of these, freaky nerd biohacker guys like myself. And you're like, I want to finish eating as early as I can. In fact, so on the way over here tonight, right, I ran in, had jujitsu, went back to the office, did my stuff, ran to my house, took a quick shower, quick fixed the Factor 75 meal, had a couple of handfuls of blackberries, and then I took my dark chocolate that I typically eat for my dessert every night, and I had it on the way over here. So by 6:20 or so, I was done eating for the day.
So you're not going to eat when you go home.
Absolutely not. No way.
But you had dark chocolate.
Correct.
So I can have a little dark chocolate every day?
I will tell you that I eat dark chocolate every day. Right?
Oh, really?
And so
how much?
Usually a bar, right? It's a Hue bar, a
Okay.
human bar. It's got usually like dark chocolate with cashew butter or almond butter on it.
Like a bar like this big?
Yeah.
You're eating
like
a whole bar of that every night? Well, that's all I need, man. I can do that.
But here's the thing. I don't do anything else wrong the rest of the day. You know what I mean?
Sure.
Like I'm not eating chips. I don't snack on stuff. I drink water. I have, usually either black coffee or a little cappuccino in the morning. And then I fast. I have my lunch, which is basically like that couple of ounces or so of vegetables with lamb and chicken on it. And then I eat my supper at night, which is usually, like I said, meat, avocado, sweet potato, or a factor 75 meal, which is broccoli, cauliflower, and a piece of protein. And so that represents the sole sum of all of my badness for that day.
Yeah.
What about the heavy metal issue with dark chocolate right now? What's going on?
That's an interesting thing, right? So, look, I got worried about this a couple of years ago because we were using a lot of balsamic on our salads. Balsamic vinegar is noted for having high lead levels. I think you mentioned Tim Ferriss. I think maybe it was him, it was somebody in sort of his circle, but they were talking about the purity of olive oil. And I think doesn't he talk about ordering olive oil from some fancy place and getting his olive oil? Maybe it's not Tim. Maybe I'm getting confused.
I think he actually does. It might have been him or it might have been Peter or Tia. I don't know.
Yeah, it could have been a Tia. But either way, the point is that they were talking about, look, so many of these oils that we're getting in the store, olive oils and stuff, are cut with like machine oil probably or something terrible like that. So I'm with you, right? I agree. There certainly could be something in that from machine parts or lubricants on these machines that make our food that are probably contaminated. I wish more people had to subject their products to third-party testing before they came to market.
Mm-hmm. Where are you buying the dark chocolate bars?
I usually get it at Kroger.
Oh, really?
Yeah.
Okay. And how dark we talking?
70%.
70%.
Now that's if I either eat that or I'll eat an 85% just regular plain dark chocolate. No almond butter or nothing with it.
Okay. All right. That's I'm good, man. Heck, if I can do that, that's amazing. How long you been doing jiu-jitsu?
It'll be 2 years this summer.
Okay. At Nashville MMA?
Correct.
Okay.
Yep.
And you work with a lot of fighters up there too?
We have an office in Nashville MMA.
Oh, no
so
way.
we have it's not really, they moved into their facility, I want to say in like September, and getting things and
September of 22?
Of last year. Yeah, that's right. Yeah, about 4 months ago.
Did they move?
They moved over to Elm Hill Pike.
Oh,
so they had
I
a
didn't know
downtown location kind of not far from
by the
downtown.
go-karts?
That's right. Right
That's
by the
where they
go-karts.
were
That's
in
where they
that
were.
huge
That's right.
building.
Yep.
Okay,
Yep.
so I didn't know they moved out of there.
That's right. They have a beautiful facility that they've done so well with. Taylor and Ben and all the guys over there have done it, and Tim and all the workers. They've just done such a great job with the gym. It's just phenomenal, and they're going to make it even better, right? As they continue to grow and they add more members and they're just going to add more classes. It's just going to get better. But we have an office in there, so there's sort of two groups of people that we serve there. There's the group who's actually on the fight card, and we're kind of working with those guys and trying to help as much as we can and keeping them well. And then we've got the crowd like me, right? These 40-year-old guys who are going in there to stay well. And we want to help them do that. We want to be able to see those guys. I feel like this whole thing, tough men create easy times create weak men create hard times, and the cycle starts over. And I think that's kind of, we're at that weak men standpoint. You know what I mean? Like if you look, I think those are a bunch of post hurdles up there, right? Yeah. Those are the weak men. And so I look at my goal as to support my generation of men, to not allow them to sort of hopefully go down that rabbit hole. And then even further than that, to take my 12 and 14-year-old boys and really instill in them a good sense of masculinity and what their purpose is, to be a leader in their community and in their family, to their wife and to their children, to their business. Because I believe that's what's going to bring our society back to where we want it, right?
Could not agree more. Could not agree more.
So that crowd, right? there's exceptions to every rule, obviously, but if you were to take the average person who practices jujitsu or some type of martial art, they're not a jerk. Those people are typically very grounded. They're just good people. And so that's the kind of group I like to associate with.
I noticed in talking with a buddy who's a black belt, one of the things that's different about him is he's very secure.
Oh, yeah.
You know, you know how some people, I mean, shoot, I do this sometimes. You know, you kind of chuckle when you're nervous or get fidgety or whatever. He's very chill, very grounded, just very secure. I mean, when you could kill someone if you really wanted to,
yeah.
you know, that gives you a certain
the
amount
pressure's
of
off.
Yeah, the pressure's off. Did you ever roll with Pete Carroll in Nashville? MMA?
No, I haven't rolled with Pete.
It's a buddy it's up there. Well, I got to let you go, but what last question, what would you consider to be your most helpful daily habit?
Oh, gosh. I have kind of a ritual, so I don't.
In the morning or?
Yeah, I do both.
All day
actually.
kind of?
Yeah, I mean, I think right now, if you ask me, like right now, I would say my evening sauna is probably doing the best for me.
Yep.
Right, like that time for me, and then go into a cold shower right after that is really paying dividends for me and my body right now. You know, and then I would probably say the next thing is the fact that I focus on eating and fast till lunch.
Okay.
Like the fasting and not allowing my body to consume calories in the morning has also paid a huge dividend for me. Right.
I've been doing that since like 2016.
Yeah.
I do not feel good when I eat breakfast, man.
No way.
I would do it on Saturday mornings because the whole family wants to eat breakfast together.
But
I just know I'm not going to
really
feel that great.
How much do you really eat? Like if you go overboard, you're going to know it. But if you pick like a little bit of egg or something like that, you know what I mean? Like I'm with you. I just don't. I don't really like the way I feel. I largely discourage my patients from eating a morning meal.
Really?
Yeah, and
Well, breakfast is the most important meal of the day.
well, you know, we were told to eat cornbread and and
true.
potatoes too,
True.
right? So,
True.
I tell them like, look, well, okay, so there's this sort of concept around chronotypes, people that sort of gravitate to doing things at certain times of the day, and so what I've seen is, when you interview 3,000 or 4,000 people a year, you start to get the idea of what the patterns are. What I've seen, Ken, is that a lot of women, probably about 20 to 25% of females, will feel better if they eat something earlier in the morning. That group of women, that 20-25% of women, will find it hard to fast.
My wife is one of those.
They typically will not do well on a keto diet. They will feel much better if they get some kind of like, the typical thing they'll tell me is, oh, I like to have some yogurt with some honey on it and some nuts and some blueberries or something like that, right? There's some kind of like mixture of that stuff, granola maybe or whatever. And getting that, whatever 200 calories or so in changes their entire day. And for those, I think that's evolutionary, right? I think there's probably just always reasons why 20% of the population should probably do something that the rest of us, because if something breaks the rest of us, we've got some people to move on.
Sure.
And to kind of carry the torch forward. So anyway, I've just noticed that segment of women needs to have something, but largely speaking, if you're not in that group, then you need to consider skipping breakfast and pushing your meal off until the later morning hours. The evidence has shown that the later in the day that you eat carbs, even if you ate, let's say, 2 ounces of sweet potatoes at 10 a.m. and you ate the same 2 ounces of sweet potatoes at 4 p.m., the glucose curve and the insulin curve associated with those are different.
Oh, interesting.
That the longer in the day that you go, the more insulin it takes to get your blood sugar to come back down, right? So your blood sugar typically stays elevated for longer, and it comes down slower, right? And it takes more insulin to get it down.
Later in the day?
Later in the day.
Well, that's a bad thing, isn't it?
It is a bad thing, which is why you don't want to eat your carbs late in the day.
Oh, gotcha.
See what I mean?
Gotcha. Okay.
So if you're going to have a carb attachment to your meal, then consider moving that to the earlier part of your day.
I see. Interesting. But then you're going to have a crash too.
Well, in theory, if you're eating 40 grams of carbs or less, which is probably all about you should be eating,
that's not gonna,
it's not going to make you
you're
crash.
fine. Yeah.
And I do this experiment for people, and I don't know how much time we have, but if you were to keep your blood sugar 80 over the course of a 24-hour period, how many grams of sugar do you think are necessary for you to maintain that level of your blood sugar? What would you guess?
I have no idea.
Okay. Let's suppose that right now, all three of us in this room decided that we were going to fast until this time tomorrow night. All we were going to drink was water. It's probably safe to say that all of us could do that, right? We'd be fine. We knew that we could fast for 24 hours. So you managed to stay alive for 24 hours, yet you had how many grams of carbs over that 24 hours? Zero. So you start to see very quickly that it doesn't take a lot of carbs to fuel the machine. In fact, it takes you only about 5 grams of carbs or 1 teaspoon of sugar can supply you with enough glucose to keep your body level for 24 hours. Now, this assumes, of course, that you're not in the hot sun, pushing heavy weight, exerting yourself to some, crazy degree. But if you look at something like 1 cup of cooked white rice, how many grams of carbs are in that? Take it even further and look at 1 cup of cooked kidney beans, which has 110 grams of carbs per cup. 22 times the amount of sugar that you need. 9 times the amount in the case of rice, which has 45 grams of carbs in it. So when you think about something like the paleo diet, and you think about the imbalance of carbs, that really makes a lot of sense, right? Because if we were hunter-gatherers and we were wandering around the earth, we would have had to have competed with every other herbivore to find beans, right? And they would have grown wild. So it wasn't like we had 25 acres of them planted in nice, pretty little rows. Yeah. You know what I mean?
Yeah.
And so what would we have found? A patch of beans as big as this room? And if we'd have gathered them all up and we had 100 people in our tribe, how many beans would you have gotten?
Yeah, not so much.
Not so much. Yeah. And the good news is that God was smart. He made it so that you only need 2 or 3 of them because you only need 5 grams of carbs. And in a little cup, there's 110 grams.
Fascinating.
And so when you think about the paleo diet, why that philosophy can serve the good of so many people, it's because by your nature, you're removing the corn, the soy, the white potatoes, the wheat, all the stuff that makes up those crappy carbs that in excess you don't need.
Yep. Are you a fan of the paleo diet in general?
Absolutely.
Really?
I told you that paleo carnivore philosophy is where I operate.
Oh, yeah?
Right? Because it allows flexibility for people.
Okay.
Right? They can have a little bit of fruit, so they get a little bit of sugar, right? So they can have some berries, they can have some fruit that makes them happy. And then I try to focus on getting that protein, right? So using the vegetable part.
I'm going to look into paleo more. One of the most jacked dudes at our gym eats paleo.
Yeah.
Has for a long time.
Yeah. It's not really that much different than carnivore. If you look at like what Paul Saladino does, and Carnivore MD, he eats a lot of fruit, but he stays away from the things like the broccoli and the kale and the spinach. And I eat some of those, but I've done the experiment to know that if I have that roughage, my function is better. And so I don't want to incorporate enough of it so that I'm chelating out my minerals, because I believe that what Paul says and the reason why those vegetables can be detrimental to us is true. But I believe that there's probably some amount that taking it is good for us, nourishing our gut bacteria. There's certain prebiotics within those fibers and starches of those plants that we need to nourish our gut bacteria. And I just don't like fruit. Honestly, I'd rather have blackberries or blueberries, but I don't like, maybe once a month I'll eat an apple, maybe. Yep. Outside of that, it's blackberries, raspberries, blueberries, things like that. I don't really eat other stuff.
Yep.
So I need the roughage that probably some people would get from fruit. I get it from some, Brussels sprouts or something.
Okay. Yep. All right, brother. Thank you for being here, man.
I've enjoyed it.
I've enjoyed it. This was fun. This was a real treat. I mean, you were wicked smart, so this might not need to be the last time you're on here.
I'd love to come back.
Thank you. I've really enjoyed this. I think there's a lot of value in this for folks. I hope there is. I know there was for me. Do you serve people nationwide or just in person in Nashville?
So we work with clients who, a lot of our clients travel extensively or have homes around. So so we have clients that live out and then come in and out of Nashville. Most of our clients are local, but we have clients who are stationed all across the country because of their travel pattern.
But if someone's in the Northeast, like, man, Compass sounds awesome, you're not doing like remote blood work and that type of thing.
We work with them to get advice, and then to try to fill in the gaps where we can, mindful of like what regulations we kind of have to be, attending to, prescribing across state lines. And, you're supposed to be sort of licensed in certain states. And so there's some restrictions that we have to abide by.
That makes sense. Yep.
But what we do is, at least try to help them get plugged in the right way if we can't serve them based off of the regulations that we're up against.
Okay. And can you give people your website and Instagram or whatever you want to give people to find you?
Sure, yeah. It's going to be www.compasshp.compasshumanperformance.com. We also have our an older website. our initial URL was compasscellularhealing.com, and so we still have that site up and running. The reason we did that was because of in the beginning, when we first sort of conceptualized what we wanted Compass to be, we saw it as a way for people to heal their cells right at that level. And so the goal was to have Compass, and then the point is that now we're really our main focus is on the human performance aspect.
Okay.
Just helping humans live optimal lives. So we got compasshp.com, and I think our Instagram is compass.hp.
Okay.
Is what that is. So look us up, and we're going to be expanding. There's a new concept coming to Nashville. I don't know if you guys are familiar with Upgrade Labs, but Upgrade Labs is Dave Asprey's biohacking concept. It's a franchise concept for biohacking. So ARCS machines, or artificial intelligence working with weights, with bikes like a Carol bike. I don't know if you're familiar with a Carol bike, but it's basically an artificial intelligence bike that helps you get more power per stroke of your legs, right? So the artificial intelligence is able to calibrate the machine while you're doing it, so that at certain parts of the stroke of your legs, it's applying more pressure than at others.
No kidding.
So you can
I
get a
didn't hear about that.
30-minute workout in like 11 minutes.
Wow.
So there's some cool stuff coming. You mentioned this lymphatic massage. One of the technologies that we'll be employing there is called the Balancer Pro, which is a sort of external compression device. Sorry, I'm moving away. It's an external compression device that helps improve lymphatic drainage.
Okay.
And so it can be applied to the waist, sort of from the waist down. And then we have an upper body unit as well. So lymphatic massage is important to us. We know it helps with recovery. But the point is that we're going to be bringing that suite of services to Nashville. It's going to open up a whole new dynamic for those people who are really looking for like optimal health and longevity and performance. So there's sort of three parts to that, which is performance, recovery, and cognition. And Compass is going to support that mission by adding the things that concept doesn't have, such as IV therapy, ozone, peptides, hormones, right? And so for the consumer's perspective, we can really touch all of their needs. And so we hope to grow our presence around Nashville and even throughout the Southeast in the coming years.
Love it. Bright future.
I hope so.
Yeah. All right, brother. Thanks again.
Thanks for having
Appreciate
me.
it. See you, everybody.
Try to catch me howling at the moon.